questions from the floor? Yes, Pooja.
Yes, ma'am. First, we started with the routine laparoscopic system. So there we found that in the initial cases, there was difficulty, subjective variation also, and the whole background also was appearing to be green. So we couldn't identify the gland exactly from the background also. So later on, we tried to check whether our own methodology was, whether it is correct or no. And then with subsequently, we could try to eliminate whether it was depending on the lighting system of the OT. All those were factors which was initially a struggle for us. Our maximum dose is 10 milligram. That is, each dose we inject 5 milligram at 2 different time points, ma'am. So we never injected more than 2 for any of the patients.
If you have to auto transplant, how would you do that? Parathyroid auto transplantation?
So once we know that this is avascular, so we take the gland and then we mince it into small pieces, and then a small incision in the sternocleidomastoid muscle, and then we can place it inside, and then close it with a small suture after it.
Dr. Suraj, one
yes,
question from our side. Out of the total 7 cases, only 4 were total thyroidectomies. The rest were 3 hemithyroidectomies.
Yes, sir. So the calculation,
but you were saying that the hypoparathyroidism...
Yes, sir, the calculation for the postoperative calcium levels was done only for those 4 patients, sir. But the identification of the gland was done with all the 7 cases included.
Okay, so that's a very small number to come to some conclusion.
Another
thing is that in your study you are saying that 70% of the glands were identified visually and indocyanine green 56%. How do you explain that?
Yes, sir, so that was one of the drawbacks also, which after I went through the literature also, which said that some of the studies, there were more glands which are identified by naked eye than ICG. So one study said that the ICG is not a better tool to identify the gland, but rather to check the vascularity of the gland at the end of surgery. Sir.
Okay.
Dr. Suraj,
yes, sir.
What is the power of your study? Because you have taken only 4 patients.
Yes, sir. Yes,
Before you would start the study, you could have done the power of the study. How many patients need to be?
Yes, sir. With regard to the calculation of the sample size, sir, we found out that minimum of 35 to 40 patients with regard to previous studies which was done, sir. But this is still an ongoing study, sir. What we propose to extend this further, sir. No, 46 was the total thyroidectomies conducted in last year, but our study, we selected only these 7 patients and we have done this ICG on these. Again, because of the logistics of our institute, we chose only the 7. The first is the availability of the dye, and also to get the ICG camera system that was in actually a separate OT. So to do thyroidectomies in that OT also, we had certain logistical issues.
Okay, then we'll go to the next case.
Yes, thank you.
Thank you. So next I will call upon Dr. Anvesh Biswas, who would like to present an audit of patients presenting with adrenal disorders.
There's a small announcement. If anyone finds a black spectacle box, please hand it over at the reception. It belongs to Professor Marthupandian, sir.
Good afternoon, everybody. Today I would like to present a single unit experience on patients presenting with adrenal disorders over the last 1.5 years. So the adrenal gland disorders that we encountered for a duration of January 2021 to June 2022 were as follows: pheochromocytoma, 4, of which unilateral pheochromocytoma was 3 and bilateral was 1 case. 2 cases of Cons adenoma, 1 case of residual Cons adenoma, 3 myelolipoma, 3 non-functioning adenoma, 1 angiomyolipoma, 2 schwannoma, 3 adrenal cysts, 1 paraganglioma with Takayasu arteritis, 1 case of bilateral histoplasmosis, and 2 cases of adrenocortical carcinoma. The demographic features of these patients were as follows. In age, the mean was around 44.9 with a standard deviation of 11.996. Median was 47.5. The range was from 28 to 65 years, with a female preponderance of 17:6 to the male counterpart. Incidental findings on imaging were 8 out of 23. That is at 34.78%. Now, the number of cases that we managed surgically during the time period was 3 cases of unilateral pheochromocytoma, for which we did right adrenalectomy, 2 cases of laparoscopic, and 1 open. One bilateral pheochromocytoma for which bilateral adenectomy was done in an open approach. One cons adenoma for which laparoscopic left adenectomy was done. One residual cons adenoma for which open excision of residual left adrenal nodule with the nodule was done. 3 cases of adrenal cyst with the removal of the cyst and the ipsilateral adrenal, 1 lap and 2 open, of which all were right-sided. 1 case of angiomyolipoma for which laparoscopic right adrenalectomy was done, 2 cases of schwannoma for which open left adrenalectomy, and another was left adrenalectomy with nephrectomy, for which laparoscopy was attempted, but it was converted to open. 1 case of splenectomy was done for which it was supposed to be a non-functioning adenoma, but during the intra-op it turned out to be an accessory spleen. 1 case of adrenocortical cancer for which open right adrenalectomy was done. The right-sided laterality preponderance was found in both operated and non-operated cases, which made it 12, that is a 52.17%, and 7 cases of left side and 2 cases of bilateral adrenal disorders. 1 accessory spleen localization failure occurred, and for another cons adenoma, the lateralization failure occurred. Now, 7 out of 14, that is a 50% open approach was taken. 5 out of 14 laparoscopy or lap-assisted cases were done, 35.71%. 1 out of the 14 cases for which we had to convert to open, and another lap adrenalectomy which was attempted, but it turned out to be an accessory spleen. Total number of cases that was operated for the year 2021, adrenal cyst 2, unilateral pheochromocytoma 2, cons adenoma 1, residual cons adenoma 1, and another adrenocortical cancer 1. Right adrenal cystectomy, the presenting feature was pain. Currently the patient is pain-free. We did an open approach. Right adrenalectomy for pheochromocytoma was done. The patient was suffering from paroxysmal hypertension and palpitation, who was on 4 antihypertensive drugs. Currently he is normotensive on amlodipine 2.5. Another lap adrenalectomy was done for pheochromocytoma. Presenting feature was hypertension with paroxysms, palpitations. Also, he had a history of AMI 5 years back. Currently, he is normotensive without medication. A laparoscopic left adrenalectomy for cons adenoma was done. Currently, the patient is without antihypertensive, and although she suffers from occasional hyperkalemia. A residual cons adenoma after lap adrenalectomy was removed by open exploration. Currently, the patient is normotensive, and no potassium supplementation is required. Right adrenalectomy for right adrenal cyst was done, but the postoperative finding was hydatid cyst of right adrenal gland. Intraoperative, we also found an endocyst. The patient was put on tap albendazole for the next 2 months. A right adrenalectomy was done for adrenocortical cancer. An open adrenalectomy was done, and the patient's serum cortisol and serum DEHS was raised, which is normal now. Now, for the time period of 2022 to June 2022, bilateral pheochromocytoma, we operated 1 case, unilateral pheochromocytoma 1, angiomyolipoma 1, schwannoma 1. With nephrectomy schwannoma, we operated 1 case, adrenal cyst 1, and a non-functioning adenoma turned out to be adrenal accessory spleen was 1. This is a case which presented with paroxysms of hypertension during resuscitation for dengue shock syndrome. We did a bilateral adrenalectomy for pheochromocytoma. Currently, the patient is on tablet hydrocortisone and fludrocortisone. A laparoscopic right adrenalectomy was done for pheochromocytoma. Currently, the patient is normotensive without any drugs. Another laparoscopic right adrenalectomy was done for angiomyolipoma. It was removed due to the size of the angiomyolipoma. Currently, the patient is asymptomatic. A laparoscopic right adrenal cystectomy with appendectomy was done. The CT scan of the patient revealed huge right-sided suprarenal cyst and recurrent appendicitis. Now the patient is asymptomatic. Another left adrenalectomy was done for schwannoma. Currently, the patient is asymptomatic. Another left adrenalectomy for schwannoma was done along with nephrectomy. Another non-functioning adenoma planned for left adrenalectomy turned out to be adrenal accessory spleen was done. And the cases not operated were as follows. 3 cases of myelolipoma was not operated because of their size, all were less than 4 centimeter. Non-functioning adenoma 2, which were both detected incidentally and less than 2 centimeter. Cons adenoma 1, it was not done due to the failure of lateralization. A paraganglioma with tachyarthrosis arteritis, the patient was unfit for anesthesia, so the patient is put on antihypertensives. A bilateral adrenal histoplasmosis patient, we put him on antifungal therapy, which is currently ongoing. And another case of adrenocortical carcinoma, which turned out to be unresectable, so we did not operate. Thank you.
Good, Bishwas. You had an excellent spectrum of cases.
Thank you, sir.
What was your criteria to select whether you would be going for a lap or an open adrenalectomy?
So it basically depended on the size of the mass. And also in some cases, mostly it was due to the size or depending on the resectability of the tumor.
Now, what criteria you have taken here?
On this cases, sir, in cases of pheochromocytoma, we decided depending on the mass of the tumor, size of the tumor.
That's what size you took for?
Sorry. So the size was, we took it more than, if it was 4 centimeter, we took it to we decided to go on an open approach.
Okay. Any questions in the floor?
Yes, sir. It was on the same site, sir. It was operated in an outside center, and finally the patient came to us, and then we decided to do it in an open approach. It was previously done in a laparoscopic approach. Yes, sir. So the size was around 6 centimeters. So more than 3 centimeters.
Dr. Ramya, yeah.
So that, ma'am, the patient only had pain and nothing. There was no other, the reports were normal and the patient also did not complain of any other symptoms. Adrenal, sir. Yes, sir. That was not due because of lateralization failure. Ma'am, because it was, I mean, the previously, no, ma'am, previously we did an anti-echinococcal antigen that turned out to be negative. We found it to be an endocyst while cutting open the specimen. No, ma'am. Yes. Yes, ma'am. Yes, ma'am.
Anyway, Dr. Anvesh, we are running short of time.
Thank
you for that good audit. You got good number of cases.
Thank you.
Very short period of time, all variety of adrenal cases. Thank you.
Thank you, sir.
Now the next presentation is by Dr. Gopal Puri. It's on evaluation of concordance of ultrasound, cytology and histopathology in solitary thyroid nodules and the risk of malignancy. Dr. Gopal.
Good afternoon. So basically, the prevalence of STN depends whether we are seeing by palpation or ultrasound detected. On palpation, the studies report it to be 4 to 5%. On ultrasound, it varies upon the who's performing the ultrasound, but is reported about wide range 20 to 76%. If anybody has a solitary thyroid nodule, the one question they need to be answered is the risk of malignancy. And accurate preoperative diagnosis improves the anxiety of the patient as well as decreases the need of diagnostic thyroidectomies. So on ultrasound, TIRAD system is used, and on FNAC, Bethesda system is used to characterize the lesion. So we did a study in the cohort of solitary thyroid nodules to compare the concordance of TIRADs and Bethesda, taking final histopathology report to be gold standard. So it was a prospectively designed observational study with the objective of to study the concordance between the two systems and as well as calculation the risk of malignancy in each category. The inclusion criteria was patient presented with solitary thyroid nodule and age more than 12 years. Exclusion criteria was patients with thyrotoxicosis, small nodules that is less than 1 centimeter, which were not operated, and patient unfit for surgery because of anesthetic reasons. So for calculation of sample size, we use sensitivity as median of 85% and specificity of 80%. And with that 90% of power, we get that we should have 82 histologically negative cases. So taking the percentage of malignancy in STN to be 10%, we decided that we need 92 cases for this study. However, in the stipulated time, we could only operate 80 patients. So this is the flowchart. Patients with STN were worked up, and then whether to undergo hemithyroidectomy or total thyroidectomy in the usual way. The risk of malignancy was calculated by total number of histologically confirmed malignancy. For neoplasm, NIFTP and adenomas were included in that. The concordance was quantitatively calculated by Cohen's kappa, and qualitative stratified analysis was done. So out of 140 patients eligible for recruitment, we could only operate 80. So this is the baseline. The majority patients were females. The age majority was between 20 to 40 years. The TIREDS category which was seen was TIREDS 3, and Bethesda most prominent was Bethesda 2. 66 patients underwent hemithyroidectomy, and rest underwent total thyroidectomy. So this shows the risk of malignancy. One pointer which I want to point out is that the risk of malignancy is increasing in the age 20 to 40 years, which has been reported in literature recently, that the malignancy is rising in patients less than 45 years. The stratified analysis of FNAC was done with final histopathology, which highlighted that in Bethesda 3 and 4, there is 47, almost equaling 47% risk of malignancy, which is much higher than reported in the literature. The concordance of ultrasound findings with the cytology revealed that 22% risk of malignancy was there in TIREDS 3, which is much more increased as compared to 7% reported in the literature, and TIREDS 4 is 31% in the literature, and we found 71%. So the concordance was calculated using Cohen's kappa after excluding Bethesda 1, equating TIREDS 2 with Bethesda 2, 3 with Bethesda 3, and 4 with Bethesda 4, 5 with Bethesda 5 and 6. The kappa was 0.21, which is fair concordance according to Landis and Koch, and the agreement which was observed was 42.67%. For better clinical, we did a regrouping of the cases that we did benign and malignant, which were concordant more or less. The intermediate category, that is TIREDS 3, TIREDS 4, Bethesda 3 and 4, was the area which fascinated us. So in this, we can see TIREDS 3, Bethesda 3, the concordant nodules agreement was only 29%. And the risk of malignancy in these concordant nodules was 42%, compared to the discordance rate 70%, and the risk of malignancy was reduced about 17%. Similarly, in TIREDS 4, the concordance was around 17%, and the risk of malignancy in concordance was higher than those in non-concordant lesions. Then we did a recalculation of the kappa, and it came out to be 0.38, and the agreement was 64%. So when we compared our studies, compare our study with those in the literature, we found that in our study, in TIREDS 3, there is significantly higher risk of malignancy, and TIREDS 4 also. And this is the comparison of risk of malignancy and risk of neoplasia in various studies compared to our study. So in our study, Bethesda 3 at 47.37%, Bethesda 4 at 46.67%, which is much higher. The Indian studies, notably from Agarwal et al., reported that 34 and 26% risk of malignancy. In risk of neoplasia, Chen et al. Reported 60 and 80%, and our study was 63 and 93%. So the strengths of my study is that there is correlation done with histology and not with FNA only, and there is composite regrouping. The limitation is that the sample size has been limited to draw statistically significant conclusions, and there was no provision of molecular testing. So on conclusion, the study demonstrates a fair concordance between the TIREDS and the Bethesda system. The most concordance is benign and malignant. The intermediate category has a varied risk of malignancy and is poorly understood. And the risk of malignancy is high in both concordant and discordant intermediate nodules, thus warranting a comprehensive evaluation of these intermediate nodules that could be on repeat FNAC, diagnostic hemithyroidectomy, or molecular testing, which is not yet widely available in our setup. Thank you.
A nice study, Gopal. What do you think might be the reason for your higher percentage of malignancy compared to other series?
Sir, two reasons. One is ours is a referral center, first thing. Second reason is that our radiologists, we have a focus center based upon endocrine surgery, so our radiologists and pathologists are trained to see these pathologies. So one is that, and other than that, yes, sir, those are the two that we
That's
have
all
emphasized.
guided FNAC or blind FNAC?
All guided FNAC, and our study included only solitary thyroid nodules. Even if on ultrasound there was another nodule seen, we excluded that case. So it's purely based on solitary thyroid nodule proven by ultrasound. So that is also in the literature. I think the reported now recent literature meta-analysis published I think last year reports it about to 20 to 45%. And in our study, overall risk of malignancy was 35%.
Have you excluded the cysts, or you have included them also?
Yes, sir. Cysts we have included, sir.
Included.
Yes, sir. Yes, sir. Thank you, sir. Very good question. So one thing I wanted to point out that ultrasound had a better concordance in terms of predicting malignancy compared to the Bethesda system. That was because of two reasons. One is that the radiologist who did the ultrasound was one, and that was the consultant radiologist that we go to for endocrine pathologies. But while doing FNAC, the FNAC was done by the senior residents of the radiology. So that senior resident changed every time. But because of the logistic reasons, we could not have the faculty to do all the FNACs. However, reporting of the FNACs was done by a single consultant pathologist. Yes, sir. Yes, sir.
Can a mic be handed over so that we can hear the question?
Yes, sir. Yes, sir. Sir, type of tumor, sir, PTC was the most common tumor. Yes, sir. Purely.
What is the total amount of category 3
Yes, sir.
FNACs in your study?
Yes, sir.
Percentage of FNACs
Sir, 27, about 27 to 28% for turrets 3.
limit as per the Bethesda? As per the Bethesda, what is the acceptable limit of FNAC category 3 can be reported? And all these were reported in your institute only?
Yes, sir.
Yeah.
I'm not aware of the
Yeah.
acceptable.
It
limit,
should
sir.
be less than 12%. So you are overcalling maybe the category 4s or others, or you are actually calling too many category 3s.
Okay.
So that could be the reason why he was saying, I mean, more number of malignancies. So too many of these things you are calling as category 3.
Yes,
so you can't exceed more than 12%. So yours was 23 or 24%. That's quite
yes,
high.
Sir. Yes, sir. Thank you, sir.
So congratulations, Gopal, on your nice study. So my question is, was there any size limit to the solitary nodule which you included in your study? You said that you excluded less than 1 centimeter, but what was the largest diameter of nodule which you set for your study? That is one question. And second question was, did you try to look into like a patient may be having thyroid's category 5, but Bethesda category 3. So did you try correlating highest category of 2, any of this thing high?
Yes, ma'am. If I am allowed to show my table, we did the second part of your study. We did that. In first part, there was no upper limit. The largest, I think, was 7.5 or 8 centimeter solitary thyroid nodule that we operated. But there was no upper size limit that we set on for, because all the surgeries were done via open approach. So there is no...
And did you correlate size with malignancy?
No, ma'am, we did not.
Because that would skew your like sampling error could be there if you try to include bigger size nodule.
Yes, ma'am. We definitely have the data, ma'am. We can calculate.
Yeah, thank you.
ma'am.
Congratulations again.
Thank you, ma'am.
Thank you for that good paper. We'll go on to the next paper now. Thank you. The next paper is on laparoscopic versus open adenectomy, a tertiary care experience in India, Dr. Rijita Haffel.
Good afternoon to all. I'm Dr. Rijuta. I'll be presenting on laparoscopic versus open adenectomy, a tertiary care experience in India. These are the co-authors in this study. and we have no conflict of interest. So adrenal tumors like pheochromocytoma or Conn syndrome have surgery as a mainstay treatment. Earlier in 2014, Endocrine Society guidelines had recommended open techniques for tumors like pheochromocytoma to ensure complete excision. But recently, more studies have shown that advantages of laparoscopic surgery over of adrenalectomy because of shorter hospital stay, because of less intraoperative blood loss and less postoperative pain. And many studies have shown proven the benefit of laparoscopic adrenalectomy. But in Indian setting, we still practice open adrenalectomy in many centers. So our aim of the study was to compare laparoscopic versus open adrenalectomy in adrenal tumors at a tertiary care hospital in India. We had a retrospective cohort study of prospectively collected data from January 2014 to May 2022 in Department of Surgical Disciplines, AIIMS, New Delhi. We included patients who underwent open or laparoscopic adrenalectomy who had indications for operating and had availability of CT or MRI or Dotanoc or MIBG imaging. We evaluated the patients by the demographic data, the size of the lesion, whether unilateral or bilateral was done, and the conversion rate from open to laparoscopic to open adrenalectomy. The postoperative evaluation was done by visual analog scale and step ladder analgesia that was required postoperatively, the length of the hospital stay, whether any surgical site infections were seen, and post-anesthetic discharge scoring system was used for the patient's discharge. Follow-up was done at 3 to 6 months, telephonically or at follow-up by visual analog scale, and recurrence was seen by ultrasound. We did the statistical analysis by the SPSS software where rates and proportions were calculated for categorical data and median and range for continuous data. Difference in variables were calculated by Mann-Whitney test and chi-square test, and a p-value of less than 0.05 was considered to indicate statistical significance. Our sample was of 100 patients where 49 were males and 51 were females. There was no statistical difference in the sex distribution and age distribution in the laparoscopic or the open group. The findings we saw were 75% of the patients were operated with laparoscopic adrenalectomy, 23% patients were operated with open adrenalectomy, and 2% patients were converted from laparoscopic to open. The median hospital stay that was seen in the laparoscopic group was 2 days with a range of 2 to 4 days, while in the open group it was seen as 7.5 days with a range of 4 to 9 days. And the post-anesthetic discharge scoring system was used when it was 9 to 10, only then the discharge was done for each patient. When the median visual analog scale in the post-operative laparoscopic group was seen, it was 2 out of 10, ranging from 2 to 4 in the laparoscopic group, whereas in open adrenalectomy, it was 5, ranging from 3 to 6. When we assess the post-operative analgesia requirement in the patients, the laparoscopic adrenalectomy group required 89% oral analgesics only as per requirement, and 10% required round-the-clock oral analgesia in the post-operative period, but none of the patients needed IV analgesics. The open adrenalectomy group required round-the-clock oral analgesia in 84% patients, while 16% patients required IV analgesics. This was statistically significant. The follow-up visual analog scale, which was done at 3 to 6 months in the post-op period, the laparoscopy group had 97 patients with a score of 0, while the rest of the patients had score of 1. And for the open adrenalectomy group, it was 56% of the patients having score 0, while 44% had a score of 1. And this difference was also statistically significant. But we see that the size of the lesion which was used in the laparoscopy group, the median size was 3.8, ranging from 3 to 5.1. While in the open adrenalectomy group, it was 7.7 centimeter, ranging from 4.3 to 10.7, which this difference was also statistically significant. When we saw the surgical site infections, the laparoscopy group did not show any, while in the open group, 3 patients had surgical site infection, which was managed with conservative management with antibiotics and local wound management, but this was not statistically significant. We did not notice any recurrence on follow-up. Our conclusion was that laparoscopic adrenalectomy remains the primary choice of surgery in terms of lesser postoperative pain, lesser requirement of postoperative analgesia, and shorter hospital stays. The strength is that it's a large study of 100 patients operated by lap or open approach, and although there is plenty of evidence already available, there are very less studies from India. The limitations is that a large prospective randomized controlled study is required to give a robust level 1 evidence regarding this. Size is definitely a confounding factor because laparoscopy group has a smaller size while the open group has a larger size. The surgeon may have a bias in choosing which patient to go for laparoscopy because if they see any difficulty preoperatively, they may choose the patient for open approach. The patients may have a bias if they wanted a laparoscopic surgery and they had to go for open, then for reporting pain or post-operative analgesia, there might be bias. Long-term follow-up is also required for recurrences. So we have moved from transabdominal laparoscopic adenectomy to retroperitoneal approach to robotic adenalectomy, and we now tackle adrenal tumors of large sizes with minimal approach as well. So more training for surgeons must be done so that more and more patients can benefit from these advantages that we saw of laparoscopic adenalectomy. Thank you.
Good study, Dr. Rituja. I would like to ask, you would have done, what are the histopathology in all these cases? Did I miss it?
No, sir. We have not presented the histopathology.
Because whether that has an implication on your study?
It does have, but we only chose the patients who were indicated for operation.
So did you see, you would have operated pheochromocytomas both in open as well as lap?
Yes.
So were there hemodynamic fluctuations, were they comparable or were different between both lap and open group?
Sir, we did not compare the hemodynamic fluctuations. We have only compared the postoperative pain and analgesia requirement. We did not evaluate the intraoperative hemorrhage or the hemodynamic instability in this study.
So because histopathology will dictate the stay of also for the patient,
yes.
but you are not taken into account that?
No, we have not taken that.
Good study. But as you know, now the open adenalectomy is not a favored surgery. Whatever surgery is being done, in majority of the cases, it's laparoscopic.
Yes.
Even tumors up to the size of 8 to 10 centimeters are removed laparoscopically. So what additional information did you want to convey from your study?
As I mentioned, sir, that we already know that laparoscopy has been, there is an evidence that laparoscopy is better. But still we do practice open surgeries and there's lack of training, there's lack of awareness as well. And in India, at many centers, we still do open surgeries. So more training is required, more awareness is required. And we also require evidence from our country. We have evidence from other countries, but we need some from our own patients as well.
How many publications are there from India regarding this open and lap?
We have 5 to 6 publications of large studies, but otherwise there are some studies which have small sample size like 20, 25, 30 patients.
Are you sure only 4 are there?
Yes, a large study, randomized are very less.
Anyway, we'll take 1 or 2 questions from the audience.
One question regarding your design of your study. It was done from 2014 to 2022.
Yes, sir.
Full data collected prospectively. Why it is written retrospectively cohort of prospective?
Because the data was collected prospectively for a project and we have analyzed the data in a retrospective manner. Like we have collected the data which was taken at the time. It was documented as a part of project and we have retrospectively analyzed this data.
Congratulations. Thank you.
So thank you. Thank you. We'll wind up this paper.
Thank you.
Thank you, Dr. Rijita. Now we'll go to the next paper, Dr. Yuvraj Devgan. He is going to present his study on role of indocyanine green angiography in early prediction of risk of post-thyroidectomy hypocalcemia, a prospective cohort study.
Good afternoon, everyone. Myself, Dr. Yuvraj Devgan. I am presenting role of indocyanine green angiography in early prediction of risk of post-thyroidectomy hypocalcemia, a prospective cohort study. We are presenting the preliminary results of our study, which is ongoing. Until now, we have conducted study in 55 patients. The parathyroid glands, they play a significant role in maintaining a good balance between serum calcium and phosphorus levels, but they're vulnerable to the injury due to their small volume and variable location. So knowing their anatomical position and vascular supply is essential to avoid hypoparathyroidism after thyroid surgery. Temporary hypoparathyroidism with resulting hypocalcemia is the most common complication after total thyroidectomy, occurring in up to 30% of patients. So reducing the rate of hypoparathyroidism is essential in improving quality of life and Some patients require a lifelong calcium and vitamin D supplementation that can also be avoided. Indocyanine green is the real-time intraoperative imaging technique that is used to reduce the chances of hypoparathyroidism in post-thyroidectomy patients. Aim of this study is to predict the risk of early post-thyroidectomy hypocalcemia by evaluation of parathyroid gland perfusion by ICG angiography using a SPY-5 imaging system, and to study the correlation between the parathyroid vascularization and post-op glandular function. We included the patients undergoing total thyroidectomy with or without cervical lymph node dissection, both for benign and malignant conditions, and patients less than 18 years of age, patients with hepatic or renal insufficiency who are hypersensitive to iodine or indocyanine green, pregnant or lactating mothers, or patients with previous thyroid or parathyroid surgery or concomitant parathyroid disease were excluded. Indocyanine green is approved and marketed as a diagnostic dye. It's an inert, water-soluble, non-radioactive, non-ionic contrast agent which enables a real-time assessment of tissue perfusion and vascularization, and reactions to the molecule are rare. It gets excited at near-infrared wavelength, and it has got half-life of 3 to 5 minutes and is excreted by the liver. We used a concentration of 5 milligram per ml, and 1.5 to 2. Up to 3.5 ml of this solution was injected intravenously. After 1 to 2 minutes approximately, images were acquired using a SPY-5 camera, and parathyroid glands, they appeared in shades of white to black depending upon the ICG flowing through them. And post-thyroid specimen removal, scoring of parathyroid was done. It was scored 0 when parathyroid appeared black. It was given score of 1 if it appeared gray or heterogeneous. It was scored as 2 if it appeared whiter, indicating a well-vascularized gland. Serum ionized calcium was done 6 hours post-surgery and morning and evening of post-op day 1 and 2. Patients were labeled clinically hypocalcemic if they developed symptomatic hypocalcemia, and they were labeled biochemically hypocalcemic if ionized calcium was less than 1 millimole. And prophylactic supplementation was not started. Calcium was given only if the patients developed clinical or biochemical hypocalcemia. This is a slide of patient with score 7 who underwent total thyroidectomy and no calcium supplementation was required. This is again patient with ICG score of 6, underwent total thyroidectomy in which also no calcium supplementation was required. This is the slide of patient with score 4 in which calcium supplementation was required initially in the oral form and later infusion was started. And this is patient with score 3 in which calcium infusion was required. Our results show that the majority of patients were female in our study, and we had 30 benign pathologies and 25 malignant pathologies. Out of our total 55 patients, 42 underwent total thyroidectomy, and 13 patients underwent total thyroidectomy with central compartment or selective neck dissections. Out of total 55 patients, hypocalcemia was seen in 25 patients, in which 10 developed clinical hypocalcemia and 15 had both clinical and biochemical hypocalcemia. And patients with score less than 5, majority of patients, they developed hypocalcemia, and majority of patients with score greater than 5, hypocalcemia was absent. And the calcium supplementation is concerned, 15 patients out of 25, they required calcium infusion, indicating the diagnostic accuracy of ICG dye about 70.9%. So hypocalcemia is caused due to the intraoperative damage to the parathyroid glands, which can occur to the various reasons. Various studies have already shown by Zaidi et al., by Vidal, Fortuny et al., and Lang et al. That ICG is a promising operative adjunct. 4 ICG score of greater than 3 had high negative predictive value for postoperative hypocalcemia. One study by Pastor et al. Has already shown, and similar results have been shown by studies by Lorenzo and Abeldarim et al. So our study also showed the overall diagnostic accuracy of ICG is 70.9%, and we concluded that absence of visualization of at least one well-vascularized gland on ICG is highly predictive of hypocalcemia, and majority of patients with less than 5 developed hypocalcemia in immediate post-op period. This score may be useful in identifying patients in which calcium supplementation can be avoided and who are eligible for the early discharge. So it's a feasible real-time technique that can be useful adjunct for us. Thank you.
Thank you. Now, any questions from the floor? Yes. Anyway, he finished well in time because of that.
Actually, the crux of the study is that we till now have recruited 55 patients, and out of them, 25 patients have developed hypocalcemia, and 15 had clinical plus biochemical, and 10 patients had only clinical. And on the basis of ROC curve, we devised a total ICG score of 5, and the majority of patients with the score greater than 5, they didn't develop hypocalcemia, and majority of patients with score less than or equal to 5 had hypocalcemia. So this score can be proposed in Indian, whereas one study internationally by Pastor et al., they have recommended a score 3 which has got a high negative predictive value, but because our Indian population is inherently vitamin D and calcium deficient population, so our results are coming slightly different from them.
Yes, yes. Your question?
Thank you.
Can you please come to the...
Yeah, I just wanted to know whether you did post-operative PTH for these patients.
Yes,
and-
ma'am, post-operative PTH was done in this patient, and we have not yet done analysis of that because we are presenting part of the study over here.
So,
So
PTH
we'll ultimately be doing the comparison of ICG scoring with the IPTH and prediction of early post-thyroidectomy hypocalcemia.
Okay, thank you.
Did you happen to, one question from here, chairperson, here, yeah. Did you happen to compare the results of hypocalcemia, post-operative hypocalcemia in those group of patients where you did not use this indocyanine green, that is your departmental data before this, versus in those who operated with this technique and then see what is the incidence,
No,
how much it is of advantage to you or the patient?
We have not done analysis of when patients in which ICG was not used versus in ICG was used. Our study was about in patient in which ICG was used, how it is able to predict the post-surgery hypocalcemia in that. So we have not done that kind of analysis, but definitely ICG is helpful in predicting a patient, because if there is no well vascularized gland, by that I mean if there is not even a single white gland, all they are gray, that indicates partially vascularized gland, the patient definitely developed hypocalcemia. There were 8 patients in our study who had no white gland, and they all developed hypocalcemia postoperatively.
We used to have scoring even otherwise, even if you don't use indocyanine green, we have post-operative hypocalcemia predicting scoring available even otherwise. So here the technique, additional technique is this indocyanine green. So it is worth looking at that data where you did not use it and where you used it.
Yes, sir, it would be one of the make a good study that we can compare without indocyanine green and with indocyanine green. Yes.
Because you must have a control, no, for your study. That would be better.
So actually, here we are presenting part of our study. We are comparing ICG with IPTH in prediction of post-thyroidectomy hypocalcemia in our study.
Okay, thank you. We have overshooting the time.
Thank you, sir. Thank you, everyone.
So next I would call upon Dr. Rizin Suraj, who would present on comparative study of perioperative parameters in patient undergoing thyroid surgery with supraglottic airway device versus endotracheal intubation, RCT.
Good afternoon. Endotracheal tube intubation is a common airway modality for achieving general anesthesia in patients undergoing thyroidectomy. The most common postoperative complaints of laryngeal pain, hoarseness, and dysphonia are attributed to this endotracheal intubation with an incidence of 15 to 50%. The anesthesia factors which are involved causing this is usually mucosal trauma or increased cuff pressure. So supraglottic airway devices lie over the laryngeal inlet. So it is hypothesized that it reduces damage to the vocal cord, postoperative laryngopharyngeal symptoms, and voice change in the immediate postoperative period. So the aim of my study was to study the intraoperative and postoperative outcomes in patients undergoing total thyroidectomy, hemi and total, with a supraglottic airway device and an endotracheal tube. It was a single-blinded randomized control trial conducted at King George Medical University, Lucknow. Now the inclusion criteria: all patients with goiter with no preoperative voice change were included in the study. Exclusion criteria was any patients with retrosternal extension, large neck circumference more than 40 centimeters, central lateral lymph node dissection required, or difficult intubation, that is mouth opening less than 35 mm, theromental distance less than 60 mm, or Mallampati grade more than 3 were excluded from the study. Now preoperatively, once the patients were diagnosed to have a solitary thyroid nodule on an MNG, we got a preoperative voice analysis done. Then intraoperatively, I measured the duration of surgery from the incision, making the incision to closure of the wound. Then thyroid difficulty scale score was also measured, and postoperatively, I had done a voice analysis postoperatively, and also sore throat was analyzed on day 1 and day 3 based on a visual analog score. Laryngopharyngeal symptoms was measured on a score, on a laryngopharyngeal symptom score, which are 4 questions. These are the 4 questions. I have a lot of sputum stuck in my throat. I feel like something is stuck in my throat, I frequently clear my throat, and my neck is numb. These are the 4 questions, and the score was made, and the maximum score was 10 points, and the total score was 40 points. And VHI 10 was used to assess the voice handicap index. It was done on day 1 and day 7. This is the voice handicap 10 statement. There are 10 questions, and maximum score was 4, and a total score was 40. Now it was a randomized trial, so there was a total of 55 patients. Arm 1 a supraglottic airway device, there are 27 patients in supraglottic airway device, and endotracheal tube was 28 patients. 11 patients in the supraglottic airway device had to be converted to endotracheal tube in view of repeated air leak and multiple failed attempts before the start of the surgery. So before the patient was positioned, there was air leak, so it had to be converted to endotracheal tube. So a total of 16 patients in supraglottic airway group and 39 patients in endotracheal tube were analyzed. There was no patients lost to follow-up. So most common age group was 37 years in SGA and 36 in ETT. Females were most commonly operated. The most common surgery done in SGA group was hemi-thyroidectomy and total thyroidectomy for the endotracheal tube. Most common diagnosis was solitary thyroid nodule for SGA group and MNG for a total thyroidectomy group. The intraoperatively, we had measured the duration of surgery and thyroid difficulty scale score. It was done to see if SGA group, supraglottic airway group, had the difficulty had increased with using a supraglottic airway device, or the duration of surgery would increase with using a supraglottic airway device. Both were statistically not significant. P-value was more than 0.05. So both were not statistically significant, but the duration of surgery was much less in ATT group compared to SGA group, but it was not significant. Now voice analysis was done pre-operatively and post-operatively, which showed significant, statistically significant improvement in mean difference. The mean difference was calculated pre-operatively and post-operatively. So that showed mean fundamental frequency, shimmer, maximum phonation time, and quality of voice was way better by using a supraglottic airway group than an endotracheal tube. Only the jitter was not statistically significant. Then post-operative subjective voice assessment also, the sore throat, the voice handicap index, and laryngophalangeal symptom score was statistically significant. Significantly better in the SJ group compared to the endotracheal tube group. This was separately analyzed for the hemithyroidectomy group and also for the total thyroidectomy group. That also showed significant difference, statistically significant improvement of voice quality in the post-operative period in patients with supraglottic airway group. Only and the significant part in this is total thyroidectomy patients. Only 6 patients in supraglottic airway device underwent total thyroidectomy, but the patients who underwent had statistically significant improvement in the voice quality, mean fundamental frequency, shimmer, maximum phonation time, and quality of voice post-operatively, and also the post-operative variables like voice handicap index and laryngophalangeal symptom score at day 7 was better in SJ group. So this was a study. There has been very few randomized control studies comparing an LMA and an endotracheal tube in India. The studies which were conducted were outside India, and this was started in 2013. The first study was conducted in 2013. They had just assessed the outcome, post-operative incidence and severity of sore throat, dysphagia, and cough. There were 76 patients. It was an RCT, and they had used a flexible LMA, flexometallic LMA. Then 2015, 64 patients were analyzed. In that, they had done a voice analysis also, and LPS and VHI also was measured. And in 2020, also an RCT was conducted. In that, they measured the hemodynamic profiles during intubation and also buckling during extubation. All these were significant. All these patients had immediate post-operative, significantly better voice outcomes by using a supraglottic airway device. They had used an LMA, flexometallic LMA. Now, the limitation of my study was that the small size of the study, there was only 55 patients which were analyzed. The cost of, I had used an iGel as an LMA supraglottic airway device. iGel is around 2,000 rupees, whereas an armored endotracheal tube would come around 750 rupees. So this was, there was an issue with that, but then what we did was that iGel was reused after sterilization. So we could, like the study was made similar like that. And the conversion of patients, 11 patients were converted to endotracheal tube because there was recurrent repeated air leak also. So supraglottic airway device decreases subjective and objective voice outcomes and laryngophalangeal symptoms without affecting the duration of surgery and difficulty of surgery. Thank you.
Nice study, Suraj. So what do you think, why they are not using LMA in all the cases?
Sir, initially it was the apprehension of the anesthetist, sir. And the iGel which we had used, it has a fixed tracheal cuff pressure. Now we have got a new and it is not a flexometallic tube also. So now we have got a new flexometallic tube with a fixed cuff pressure of 40. So now they have started using more patients, they're giving more patients in supraglottic airway device, sir. Instead of use IGEL, if it comes out, it is very difficult to put it back again. And when there's positioning, repositioning also, it is a stiff structure compared to a flexometallic. So that was the issue, that there was a lot of conversion of patients.
Does the duration of surgery have an effect on this?
The duration of surgery, there are 6 patients in which there was air leak during the surgery, sir. So we had to halt in between the surgery because the tidal volume had come down. But it was not statistically significant. Duration of surgery was not affecting that whole duration.
Rishin, one question. As an endocrine surgeon, will you prefer to go for a supraglottic airway or a endotracheal intubation?
So supraglottic airway for sure, sir.
Because almost 16 cases failure is there, no?
Sir, 16 cases were not failure, sir. Only 11 patients were converted, sir.
Totally, how many cases were there?
Total,
how many cases tried? How many failed?
16, sir. Total 77 patients were randomized to supraglottic airway device, sir.
Okay.
11 failed, sir.
Okay.
So 11 had failed. Initially, it was failing because they had a low threshold. The first year resident would be putting, and they had a low threshold for converting to endotracheal tube. Now, after we got a flexometallic supraglottic airway device with a fixed cuff pressure, now they are giving, we tell them which to put, endotracheal tube or supraglottic airway device to put.
And regarding selection of patients, you were already mentioned retrocranial extension cases are excluded.
Yes, sir.
And is there any cutoff for tracheal lumen or anything like that? Any other concerns?
No, sir.
Other than Mallampati scoring and retrocranial extension, any other exclusion criteria, sir?
Sir, we had not taken any tracheal, based on tracheal lumen, we had not excluded any patients, sir.
Okay. About OSA patients?
OSA patients, who had obstructive sleep apnea was also excluded from the study, sir.
Thank you.
Dr. Anjali.
Yeah, congratulations.
Thank you, sir.
On your study. So I just want to ask you, when you randomized the patient, did you take into account the type of surgery? Because as we could see that majority patient in ETT group have total thyroidectomy, and like in extension to Aromal's question also, like you excluded retrosternal, but did you take into account extrathyroidal extension or malignant group also? And if this thing add upon that Dalpati's question also, why we are not using ETT regularly? So what is the fear?
Ma'am, the patients in which there was conversion was mostly total thyroidectomy patients, because that were the patients in which the anesthetist found they were very apprehensive to give it in and supraglottic airway device. Now the issues which we had faced when we were putting a supraglottic airway device was that positioning the patient. Once the IGEL is put, then we position the patient. So that time there would be air leak, and then it would get converted to an endotracheal tube. But surgical wise, there was no issues, ma'am, during the surgery.
No, but you didn't take only hemithyroidectomy or
no,
total thyroidectomy?
That was randomized. Even if there are a lot of patients who were hemithyroidectomies which went for endotracheal tube also. It was randomized.
Okay, I can add upon that because we tried doing like daycare thyroidectomy using this supraglottic airway system. So that time the majority problem we faced was as soon as if we tried to turn the patient neck, it used to come out. And if you fear that this patient might develop tracheomalacia or patient is having any other spasm problems, you would not like to use this device in those cases.
Yes,
okay, thank you.
Dr. Ramya? You had a question, I suppose?
Okay.
Yes, ma'am.
Total in your center. And the second question is, the reason why it is difficult to continue LMA for a long time is because there's no control of how much air goes into the GI system, the stomach. So they need to, if it prolongs, they need to invariably insert a Riles tube, that is NG tube. So that also is going to affect the feeling that the patient is going to have postoperatively in the throat. So was that also accounted for? Was Riles tube used in your study? That's what I wanted to ask.
Ma'am, the IGEL has an inbuilt gastric, the support for inserting the gastric tube. The first part of your question, ma'am, the duration of surgery, hemithyroidectomies, we used to finish it in around 60 to 65 minutes. So duration of surgery was much, it was less, actually it was less in endotracheal tube compared to a supraglottic airway device, but it was not statistically significant. And every patient, most of the patients, if they had put a gastric tube when the patient was put in iGel, when the patient was intubated in iGel.
So don't you think that the sensation in the throat, the pain and all, because whenever we routinely, if we need Ryle's tube for identification of esophagus intraoperatively for complicated cases, post-operatively patients complain of more discomfort in the throat. So don't you think that would have affected the outcome because that was one of the...
Ma'am, the Ryle's tube goes inside the LMA, ma'am, so there's no
I'm
touch.
talking about the throat, the sensation in the throat.
Yes. Yes, ma'am, but it doesn't go, ma'am, it doesn't touch the mucosa. The Ryle's tube goes through the eye gel, doesn't go outside the eye gel. So it doesn't touch the mucosa of the pharynx. So there won't be any issues. It won't affect the post-operative outcome, ma'am.
Okay.
Yes, sir. Sir? Yes. Yes, sir. We haven't extended to using patients with long-standing goiters and large multinodular goiters. We haven't tried using an endotracheal tube. I've excluded all that patients, sir. Only small goiters with the neck circumference less than 40 centimeter only, we have tried using supraglottic airway device, sir. Thanks.
Okay, Dr. Ujin, thank you for your nice presentation. Thank you.
We concluded the session. I thank Dr. Dalpati sir and Dr. Pradeep sir for chairing the session.
One announcement to make. Actually, the quiz winners are Dr. Antare Bhattacharya from Medical College, Calcutta, and Dr. Adarsh Raghavan from MMC. Both share the prize. Thank you.
Moving on to the next session, this will be a panel discussion on safe thyroid surgery. I invite Dr. M.J. Paul to be the moderator for this session, and I invite Dr. Aramal Chekawar, the first panelist of the session.
Thank you. So this session will cover some aspects of the safety of thyroid surgery. We are not covering the neuromonitoring because there's a discussion tomorrow. So opening will be Dr. Arumal, who's a consultant at the Travancore Medicity, Kollam, and he will speak about the extent of thyroid surgery.
Good evening to all. So it is really a privilege to present before Dr. M.J. Paul sir. So it's all about extent of thyroid surgery. There is always a debate. And now our friend, interventional radiology people also coming up, they're also having a part of it. Like, you really want to operate it? If you operate, what extent you should go? So our data in future, we are going to have a comparison data with the IR people. So I'll be discussing that whole topic based on the categories. In benign Bethesda 2 cases, Bethesda 3, 4, 5 cases. We call it as indeterminate group, and Bethesda 6 cases. So what surgery should be required? Like lobectomy, subtotal thyroidectomy, Dunhill's procedure, near total thyroidectomy, total thyroidectomy. I think Paul sir might went through the subtotal thyroidectomy, Dunhill and all. Whenever we started our residency, we started seeing total thyroidectomy only. So with practical experience, we don't have much experience in all these Dunhill procedures, subtotal thyroidectomy. So what is the standard of care in these days? So if you are, if any patient is coming to you with a Bethesda 2 category, like with a very minimal risk of malignancy, first of all, we'll be looking at why we are operating the patient. For example, if it is a solitary thyroid nodule with retrosternal extension or the growing size with the compressive features, and unfortunately, nobody came to me for a cosmetic reason till so far. I think people are not interested in cosmetic surgeries nowadays, I think. And regarding multinodular goiter, same thing. Is it involving a unilateral lobe or bilateral lobe involvement and the hyperthyroid cases? So if you are having a solitary thyroid nodule, we have to offer two surgeries for the patient, hemithyroidectomy versus total thyroid. I am not mentioning subtotal and all those things here, because here the debate is between hemithyroidectomy lobectomy versus total thyroidectomy. So the concern is recurrence. The patient will be asking one question, doctor, if we are keeping one normal lobe on the other side, what is the advantage, what is the disadvantage? I always tell them, sir, doctor, can I avoid thyroxine? So I will tell, okay, to an extent, you can avoid thyroxine in future. For example, if you are not on thyroxine till now. Second thing, there is chance of recurrence is there or not? Yes, there is slight risk of recurrence is there. And is there any difference in recurrence? When I moved from North India to South India, thyroiditis increased drastically. Similar way, the nodules encountering is also slightly different. So if you go through cases who underwent unilateral hemithyroidectomy or lobectomy for a solitary nodule, actually literature is less, like the follow-up literature is less. For example, in few studies, in small series studies, recurrent rate in contralateral lobe in future follow-up of 10 years is around 44%. And it is more in male gender. And few studies is having almost 48% recurrence in contralateral side. And in MNG, it's almost, for example, if you're operating a nodules only on one lobe and preserving the healthy lobe, there is almost 76% of recurrence rate. So, but if you're coming to the newer randomized control trials for levothyroxine in these cases and all, that much numbers are not there, but there is a bias in smaller studies, and literature is little bit limited in this follow-up in recurrence in the contralateral lobe. So if you see these unilateral thyroidectomy cases, in more than 2 centimeter size, the recurrence rate is higher, almost 70% is there in solitary thyroid nodules. And if you see colloid nodules and adenomas, there is a high risk of recurrence compared to thyroiditis cases. So, but if you are going to operate a patient having solitary thyroid nodule with a thyroiditis, you are going to preserve a diseased lobe on the opposite side. So, avoiding thyroxine is not necessarily you can offer to the patient. So, reoperation rate and recurrence rate is a concern if you are performing a lobectomy. If you are performing a thyroidectomy, complication rate is slightly higher side. But in experience hand, it is not that, it is also comparable only. So, reoperation rate is only 14.7%. So, in iodine endemic area, actually recurrence rate is slightly higher. That's what I told. Geographical location is also matters in recurrence rate post lobectomy. So, in 1992, there's a paper from Delbridge. From there onwards, like your complication rate is almost similar in hemi versus total. And after 5-year follow-up rate of clinical trial, nowadays, if you compare subtotal versus Dunhill versus total also, the recurrence rate is more in subtotal, recurrence rate is minimal in total. And slight increase in transient hypoparathyroidism rate is noted in total thyroidectomy cases. But it's far comparable in experience, and so I always offer my patient, you choose your destiny, you want a lobectomy or a total thyroidectomy. Then I always tell my patient, if you are having thyroiditis, high TPO antibodies, or you are having thyroiditis in histopathology, you can't avoid thyroxine compared to a normal thyroid lobe you are having the opposite side. So choice is yours. So recurrence rate in solitary thyroid nodule is there. Recurrent rate in MNG unilateral cases is also there. Hemithyroidectomy won't avoid thyroxine replacement. So recurrence versus complication in lobectomy is also a concern. So choices with the patient. You can choose between lobectomy or total thyroidectomy. But comparing subtotal versus Dunhill's versus total thyroidectomy, it is having comparable results only, so better to go for a total thyroidectomy. So deal one area or other area, let the patient choose which area they want to operate. So always surgical choice taken after discussion with the patient. Then comes the most controversial area, we call it as indeterminate nodules. From guidelines to literature, after everything, we will square back to zero, as always. So if you see, Bethesda 3, we are having two categories, AUS and FLUS, and in 4, follicular neoplasm and all those things. So if you go through if you include NIFTP also, the risk of malignancy, actually one talk we were also mentioning in the site, Siddharth was talking about that only. The risk of malignancy is almost 10 to 40% in 4, 6 to 8% in category 3. So as a physician, as a thyroidologist, once a patient come back to me and ask, doctor, you did an ultrasound, told me I will do a fine needle aspiration cytology, and at last you will ask, am I having cancer or not a cancer? I told, I'm really sorry. You are in category 3, your risk is only 15 to 18%. So they won't be happy. So what else you can offer to these patients? So what is the problem? So if you are in category 3, so few of my colleagues will tell, okay, we will actively surveillance the patient. But I always tell them, whenever you are reading a recommendation, go between the lines. They are written like, consider the ultrasound report. If I have to consider the ultrasound report, I should have a very efficient radiologist. So that reproducibility is very important. And you should go through the clinical features, any family history, any radiation exposure, all those things really matters. And you have to go through high-risk features in ultrasonography as well. So after considering all those things, still, if you are having a very high-risk nodule, but your FNAC report is Bethesda 3, you can combine these two. And you can take a decision that go for surgery or not, but tell them the possibility of malignancy is less. So what about a repeated FNAC? So if a patient prefer more of a conservative management, go for a repeat FNAC after 6 weeks. Then another thing is molecular testing. Really molecular testing is having a role in this or not? Yes, it is. So when you're planning for surgery in this category 3 and 4 lesions, if it is a solitary lesion, problem arises. You are going for a lobectomy or going for a total thyroidectomy. So if you go for a lobectomy, as I mentioned, if you're only considering the Bethesda criteria, the risk of malignancy will be in 3, it is around 18%, 4, it is around 30 to 40%. So you are going to, after surgery, you're doing a lobectomy. The end of the day, it may turn malignant as well. So the problem is there is always a possibility of a completion surgery in that. And there is always a possibility that you have to do another surgery also. So is there any role of molecular genetic studies in that? Yes. If you do a rule-in, rule-out or rule-in, rule-out test with a cost-effective method, two ways it will help. One thing is, you are having an indeterminate cytology. You are doing a rule-in test. If you are doing a rule-in test, you are getting a positive report in 7-gene panel. So it is more probable to have a malignancy. So you can deal it like malignancy. Like you can combine with a lymph node dissection, you can have a radical approach. If it is a rule-out test, here I can help my colleagues. Okay, we can do surveillance. And if you are having a rule-in or rule-out test, definitely you can think about planning a oncological thyroidectomy. So this way we can combine. So if the final decision should be taken by the patient, so tell them your risk of malignancy is this much, but if there is a risk of malignancy, if I'm going to operate to you, I'll go for an oncology thing based on molecular analysis or other high-risk categories. So the surgical plan is entirely depending on your molecular analysis, if it is possible. Otherwise, you can use the terads combining with that. If the lesion is more than 4 centimeter, you can very well go for a total thyroidectomy. If the lesion is 1 to 4 centimeter, there is an option for a lobectomy. So is it safe or not? So advantages like, as in benign condition, you can preserve the hormonal function, chance of less injury to recurrent laryngeal and hypoparathyroidism, but you can have a better follow-up using thyroglobulin assay and no need for second operation if you're going for a total. So if you consider the history, aggressive histology will be there in 0.5% patients. 12% can have, if you are going for a lobectomy, 12% can have angioinvasion, 17% we have exothyroid extension, positive lymph node in 18%. So completion thyroidectomy may be required in 40% of patients of 1 to 4 centimeter lobectomy. But if you go into the recurrent status, it is not that worse compared to our second surgery pattern. It's only 8.3 and 4.4% in lobectomy. And newer studies are coming with the reports telling that there is risk-free survival is always comparable. So always tell the patient, you may have a second surgery if you find these lesions, but the survival is almost similar, so we can plan accordingly. So this is a simple algorithm. If anybody is having a prior radiation, negative family history, no metastasis of lymph nodes, less than 4 centimeter, lobectomy is a possibility. But always mention them, you are having a possibility of a second surgery. But if there is distant metastasis, bilateral nodularity, clinically positive lymph node, more than 4 centimeter, poorly differentiated tumor, go for a total thyroidectomy. So before planning surgery, always foresee for complications. So end of the day, let the patient decide. Thank you.
Thank you. Thank you, Aramal. That's well covered. Actually, invite you to join me here. We'll form the panel. We'll go through all the presentations because we are running a little behind time, and I'll take questions with the panel at the end. The next is Dr. Ravi Kumar, who's endocrine breast surgeon at Coimbatore. We're happy to have him here in the past, and he's going to talk about minimizing the scar, the cosmetic aspects of thyroid surgery.
Good afternoon, everyone. I'm Dr. Ravi Kumar. I finished my MCH from Madras Medical College, and I briefly worked in CMC Vellore, and I am now working in Coimbatore and so many hospitals. I am a visiting consultant there. My topic is surgical approach and tools to minimize scar. This will be a simple topic, and I will finish it fast. What is the importance of incision? You can see the scars, keloids, hypertrophic scar. Now, cosmetic outcome is an important factor in thyroid surgery. You have to give cosmetic outcome also, whatever the size of the nodule or whatever the size of the gland. Coming to the varieties of thyroidectomy, basically thyroidectomies can be conventional open thyroidectomies, or a mini incision thyroidectomy, or a minimally invasive thyroidectomy. Minimally invasive thyroidectomy can be again subdivided into MIVAT, that is minimally invasive video-assisted thyroidectomy, or endoscopic thyroidectomy, or robotic thyroidectomy. Coming to the conventional open thyroidectomy, the usual conventional open thyroidectomy, we select a skin crease for incision, and the incision will be standard incision like 8 to 10 centimeters incision. And if you put a too much small incision and if you use tense retraction, and this will cause more damage to the skin and it will cause hypertrophic scar rather than a longer incision. And some outdated instructions like go 2 finger breadths above the suprasternal notch or go 1 centimeter below the cricoid cartilage are outdated. Always select a skin crease, the apt skin crease for incision. Incision plan should be made in the OPD with patient in sitting position. And select a skin crease, not somewhere else. And avoid keloid forming areas. Don't select too much lower skin crease. And incision plan should not be done in the operating room. Don't decide on the table after scrubbing and everything after painting. And always mark the incision. How to mark it before incision, that's all. And coming to the other techniques like what is the voltage levels to use for just you incise it and you use diathermy for deepening the incision. Always use low voltage settings in diathermy, and it's always preferable to use cutting mode rather than coagulation mode while deepening the incision. And what is done in CMC is that these are the settings followed in CMC Vellore, I think. And they use pure cut for cutting, and they use fulguration technique for coagulation, and they use precise for bipolar settings. Everything is set at 25. And coming to the skin closure, I think everyone follow this. Subcuticulous suturing gives good cosmesis. Even still, many are using simple sutures for closing the thyroid incision. And always use thin sutures. Use 4-0 monocryl rather than a 3-0 or 2-0 absorbing sutures. And if you are using a 3-0 non-absorbing switches like proline or ethylene, you can remove it after 1 week. But always use a subcuticular switches. And regarding the drain tube DT placement, you can always go just near the main wood and always select a skin crease for inserting your drain tube, and avoid drain tube over the sternal region or side somewhere else. Always make it closer to the main incision wound so that this will also appear as an incision scar. And these are some of the pictures of open thyroidectomy. You can see the cosmetic outcome if you put it in a correct skin crease. Coming to the other techniques of thyroidectomy, I will rush through. A mini incision thyroidectomy, it's not commonly followed. They use 2 to 3 centimeter incision. They put the incision and directly go to and they will cut all the subcutaneous tissue, platysma and everything. They directly enter the deep fascia. And flaps are not raised in these surgeries. You can see a 3 centimeter incision scar, and they are doing total thyroidectomy through this incision. And this is the cosmetic outcome in mini incision thyroidectomy. And coming to the other forms of minimally invasive thyroidectomy, the first one is the MIVAT, that is minimally invasive gasless video-assisted thyroidectomy. They use around 2 to 2.5 centimeter incision, and they use specific instruments and camera system and a lifting up system. So this was started way back in 1995-96, and this is not followed nowadays. In other areas, they are doing in Italy, I think. These are some of the steps done in MIVAT. And coming to the other forms of minimally invasive thyroidectomy, coming to the endoscopic thyroidectomy, all these things will be touched upon detailedly tomorrow, so I'm just giving the names alone. The types of endoscopic thyroidectomies performed nowadays are bilateral axillary breast approach, transoral endoscopic thyroidectomy vestibular approach, and transaxillary approach. These are pictures for transaxillary approach, and you can use this BABA approach. And transoral endoscopic thyroidectomy vestibular approach. Coming to the robotic thyroidectomy, this is coming up more faster than previously thought. The 3 techniques commonly used are retroauricular facelift approach, transoral approach, and rabbit approach. This is a robotic facelift hairline approach. They just go through the retroauricular area, they use an incision along the hairline, and they go and operate. This transoral approach, similar to the transoral endoscopic approach, they use a robot here. And this is robotic assisted breast axillo-insufflation thyroidectomy. Here they use the gas, and it is similar to BABA technique. That's all. And in cosmetic terms, the quality of scar is more important than the actual length of the scar. Always select a skin crease. You can use a liberal incision also, but avoid too much tense retraction, then the scar will be good. And use a subcuticular suturing. And correctly placed skin crease incision gives good cosmetic outcome compared to other things. Thank you.
Thank you. Thank you.
This is the case. You can see the scar here. 6 months after that, you cannot see the scar. If you go through proper skin crease, the cases will be like this. Thank you.
Good. That's a nice result. As the talk, please join us here. We'll take the questions at the end of the panel. Then
thank you.
We need a couple more seats. Yeah. Who's next? We have Dr. Smita Rao is next. Dr. Smita Rao will be talking about nodal dissection, safe surgical techniques, and management of chyle leak. Dr. Smita is an assistant professor at the KS Medical Academy, Hegde Medical Academy at Mangalore. Please go ahead.
Good evening, everyone. So my part of the discussion with safe thyroid surgery is the nodal dissection, the safe surgical techniques, and management of chyle leak. So I would start with be safe then, sorry. With the background, we've already discussed William Halstead yesterday. He said it was a supreme triumph of surgeon's art. But there are a lot more operations today which are delicate and perhaps more difficult. But any operative problem like thyroidectomy propounded so long ago, attacked by so many people, called it butchery and avoided, has yielded results as bountiful and so adequate because of our practices today. So nodal dissection, papillary thyroid carcinoma out of the differentiated thyroid cancers has higher rate of central and lateral nodal mets ranging from 40 to 90%. Level 2 to 4 and 6 are commonly involved. Level 5 is debatable. New AJCC staging system puts most of them in stage 2, even if more than 55 years. The risk factors to avoid recurrence are very young, very old, extremes of age, large tumor size more than 4 centimeters, multifocal disease, extrathyroidal extension, known lateral nodal metastasis, bilateral disease, male gender, lymph node size more than 3 centimeters, lymph node ratio, that is positive nodes divided by retrieved nodes more than 0.3. So this is to highlight that most of these central and lateral nodal mets come under stage 2 under the recent AJCC. So what do the guidelines say? The group which propagates prophylactic neck dissections, central neck dissections particularly, is for the high-risk group, significant family history, radiation exposure, multifocal disease, suspected extrathyroidal extension, and large tumor size, more than 4 centimeters, and T4 lesions. But the accepted category is central nodes and lateral nodes, which require neck dissections. So the ATA recommendation, therapeutic lateral compartment neck node dissection should be done for biopsy-proven metastatic cervical lymphadenopathies. So coming to the technique, the boundaries for the central nodal dissection are between the hyoid to the clavicle vertically and carotid on either sides. Lateral nodes, it extends from all the way from the skull base to the clavicle, sternocleidomastoid, anterior border of trapezius on either sides. A routine skin crease incision used for thyroidectomy can be used for the neck dissection. Omohyoid is divided to approach the carotid sheath. All fat fascia lymph nodes should be removed, particularly the posterior part of carotid sheath needs to be cleared. It can be done with a cautery or a harmonic scalpel, as discussed earlier. On the left side, particularly, the thoracic duct needs to be identified and ligated. Transverse cervical artery and phrenic nerve needs to be identified, especially in the level 4 region, preserved under the deep fascia. Spinal accessory nerve, which is the most important, causing the shoulder morbidity, in the level 2B and 5A regions, going under the sternocleidomastoid, needs to be preserved. 30% in literature can be injured during this maneuver. Brachial plexus injury to be avoided, particularly in level 4 and level 5 dissections. If need be, if involved, internal jugular vein can be ligated. Central dissection, especially underneath the carotid sheath, the sympathetic chain can be endangered. This is a new classification by Orloff group for the central nodal dissection, which is categorized into area A, B or D, and area C. Area A is subplatysmal level 6 nodes. Area B or D is right and left paratracheal nodes, the adipose tissue between the neurovascular structures, esophagus posteriorly and thyroid lobe anteriorly. Area C is deep pretracheal nodes below the strap muscle. So the proponents of central nodal dissection suggested these advantages. There's better staging, radioactive iodine treatment is feasible, and the drug dosing is adjustable. Decreased recurrence and reoperation rates because of the removal of the disease. Probable improvement in overall survival, we don't have evidence yet. So I have more than 10 commandments here to give. Preoperative counseling, explanation of the surgery in detail with the models, particularly, complications and their probable occurrences when you do it. Detailed workup according to the guidelines. Formulate the right management protocol in your OPD. A written consent needs to be taken. Preoperative surgeon performed ultrasound preferably to plan the incision, also to note the disease. Plan the incision well, as already discussed. The must-dos, don't stick to the clock, again, as already discussed. And meticulous surgery sets you apart, even if you don't stick to the time. Be economical. Don't repeat your steps. If there's a difficult step, change your step. Right position. Need not be extreme hyperextension, it's the classical rose position. Raise the flaps adequately, especially for the central nodes up to the hyoid and the skull base. Find the middle thyroid vein, try and ligate it so that you prevent avulsion. Preserve EBSLN, identify and preserve parathyroids and recurrent laryngeal nerve in full length. Recurrent laryngeal not seen is considered damaged. So identify the pointers, identify it in full length. Minimal handling of parathyroids to preserve the vascularity. Inspect the thyroid bed well after your surgery and confirm hemostasis and all vital structures at the end. So drainage for a minimum of 48 hours is not harmful, prevents unnecessary aspirations. A well-done thyroid surgery should have a complication rate of less than 1%. Audit yourself. Use adjuncts in today's era for nerve and parathyroids. Removal of all thyroid embryological remnants, which includes pyramidal lobe, thyrothymic res, and tubercle of Zucker-Kendall. Be watchful of bleeding near the Berry's ligament, and do Valsalva at the end to check for bleeding. So this is the data published by the SGPGI group of reoperative surgeries which were referred from peripheral centers. So as obvious, high volume centers had lesser complications. The deficiencies in the peripheries were inadequate surgery against recommendation, referral to radioactive iodine despite inadequate surgeries in 45% of patients, and also in hemithyroidectomies in 32% of patients. Inadequate documentation of the status of parathyroids and recurrent laryngeal nerves. Thyroidectomy can be done as day care surgery. It is as safe. The concerns are hematoma, possible reality under high volume thyroid surgeons. Newer energy devices can be used to minimize bleeding. Hypocalcemias can be prevented by a routine postoperative pH or a prophylactic calcium and vitamin D. Recurrent laryngeal nerve, try and avoid injuries, use adjuncts. Patient proximity to the hospital, patient awareness becomes more important. Difficult cases need to be avoided as day care. Patients with serious comorbid conditions also need to be avoided. Minimal access thyroid surgery is as safe as conventional surgery today. So coming to chyle leak, most commonly seen on the left side, accounting for 2 to 8% in the literature, commonly seen after 72 hours of surgery, usually during neck dissections, specifically during central compartment neck dissections and lateral neck dissections. Previously irradiated patients and the advanced stage of the disease also becomes high risk for chyle leak. So this is a study published in 2017. This is to highlight that central compartment neck dissections also can have chyle leak, and the maximum percentage of chyle leak is seen with left lateral neck dissections. So this is also from the same study, which tells you the importance of duct ligation during surgery, which reduces the output. This is as part of management of chyle leak, so which reduces the output from 800 to 23 ml later on. So this is the length of the study between two groups which were advised a low-fat diet for the dietary management for chyle leak. So the group A had a reduced chyle leak at the end of 2 days, while the group B had persistent chyle leak. So this was another paper published in 2017. This is to highlight that the surgical management was mostly in the advanced stage of the disease and lateral neck dissection. Most of the others were managed conservatively. So clinically, how do we detect chyle leak? Sudden increase in drain output, especially immediately following enteral feeding. Supraclavicular erythema, lymphedema, and palpable fluid collection. Creamy or milky drain output. Biochemically, triglyceride level in the drain more than 100 milligram per deciliter. Drain triglyceride more than the serum triglyceride, and presence of chylomicrons. So treatment, try and prevent chyle leak as much as possible. If injured, intraoperatively identify it, ligate the duct, suture fascia or muscle over the duct leak. We could also use fibrin sealants, sirolimus, cyanoacrylate as topical agents. Post-operatively, if diagnosed, conservative management most of the times with medium chain triglycerides, high protein diet, total parenteral nutrition, vacuum-assisted dressings. Octreotide can be tried if it's persistent, 50 micrograms for about 2 weeks, and tranexamic acid, TID, for about 5 days. If it still persists, then the minimally invasive approach, which is percutaneous transabdominal cannulation and embolization, can be attempted. And if that still persists, then resurgery to ligate it abdominally or a thoracoscopic approach. So this is to summarize it. Initially dietary management, if the chyle leak persists, total parenteral nutrition. If it persists further, surgical exploration, and despite that, you could try minimally invasive approaches. Thank you.
Thank you, Smita. That was well covered. Large topic. Please come and join us. So, next speaker, we have 2 dropouts. The order has changed. Geetika. Yes. Dr. Geetika Nanda will present on preserving parathyroid function. Is additional professor at the Department of Surgery in King George Medical University.
Thank you, Paul sir, and to all the IAS office bearers for giving me this opportunity to be here on the stage in front of you. So, preserving parathyroid function is very important, and as we all know, majority of this topic has been covered very well in today's by Dr. Friedrich. So I think I just need to rush through and just tell my opinion about how do we preserve the parathyroids. So Dr. Cocker, he had actually initially in 1883 itself, it was discovered that tetany was one of the most important post-operative complications occurring post-thyroidectomy, and tetany was more attributed to a kind of hysteria till it was discovered that it was parathyroid injections, or calcium deficiency was the cause for leading to hypocalcemia in 1909. So what are the complications? If hypocalcemia occurs, patient can have immediate complications in the form of neuromuscular excitability and occasionally psychosis. Then in the long term, patient can have ectodermal changes, basal ganglia calcification, increased QT intervals, and cardiac arrhythmias. So obviously we need to do something about it and also try to prevent it as much as possible. Now, what are the causes post-thyroidectomy for hypocalcemia? It could be a parathyroid gland ischemia or release of endothelin-1 post-surgery, or a hypothermia which has occurred, which could lead to temporary hypoparathyroidism. Calcitonin release and hungry bone syndrome are the causes of temporary hypocalcemia without hypoparathyroidism. A parathyroid removal or vascular necrosis can lead to permanent hypoparathyroidism, and sometimes it could be just hemodilution when the ionic calcium values can really tell you. So what is a biochemical hypoparathyroidism? Is when the PTH levels are lower than the laboratory standard values and the threshold which is taken is below 12, along with hypocalcemia. And hypocalcemia is fall in the total serum calcium levels below the lower limit of center specific range. For ionized calcium, we take it less than 1 millimoles. Now, clinical hypoparathyroidism is a biochemical hypoparathyroidism plus features of hypocalcemia. It is transient when it occurs for less than 6 months after surgery, and it is called permanent when it occurs for more than 6 months post-surgery. Now, incidence was very well told, 19 to 38% for transient, and for permanent it's up to 3%. Now, if you look at the arterial anatomy of parathyroid, it is the inferior thyroid artery which predominantly supplies both parathyroids, and it is a terminal end artery. It's a small friable artery, so we have to be very careful to preserve it. We should also be very careful about we should be very much be knowing about the position of both superior and inferior parathyroids. It was also very well dealt in the morning's presentation. So I don't need to explain again in detail, but yes, we all know that majoritarily the superior parathyroid is more constant in position, and it lies anywhere in the region of 1 centimeter above the junction of superior thyroid, the inferior thyroid artery and the recurrent laryngeal nerve. And inferior parathyroid is more variable in position, and it could be lying at the posterolateral aspect of inferior pole of thyroid and somewhere in the area around it. So we should be knowing thoroughly about the relation of parathyroids and also their relation to the recurrent laryngeal nerve. Now, inferior parathyroid lies anterior, while the superior parathyroid lies posterior to the nerve. So that should be clear. And we should also be knowing about how parathyroid looks, so that we don't confuse it with the other structures which are lymph node, fat lobule, or a thyroid nodule. These are the structures which we often confuse with. And I would say that the most important points which distinguish the parathyroid from other structures is the meshwork of blood vessels which are seen over the parathyroid, a blush which appears if you give a little nick over it, and a small body which is moving in its own capsule. So these three things are usually seen in parathyroid and would not be usually seen in other structures. Now, what are the causes of parathyroid injury? One is there is a direct injury in the form of devascularization, or there is a venous engorgement, or the parathyroid has been excised accidentally. There's a difficult anatomy of the parathyroid itself, or it's a difficult surgery. So we would deal with the first thing first, which is direct injury. Now, as we all know, that if the parathyroid is there, the classical method which has been recommended is the Halsted method of parathyroid preservation, which is that you ligate the thyroid artery beyond the origin of parathyroid artery close to the contact point with the thyroid parenchyma. And this is also referred to subcapsular procedure. Now this has been documented in the literature long time before, as early as 1907, but it still holds the value. Sometimes the parathyroid artery would go into spasm, and a topical injection of papaverine or lidocaine has been documented by some studies to be causing reversal of the spasm and in turn improves the rate of hypocalcemia postoperatively. Alternate energy-based dissection devices in the form of harmonic and ligashore and the use of loop magnification has also been shown to decrease the injury to the parathyroid vasculature in various studies. A subcapsular saline injection of thyroid gland at the level of cricoid cartilage has also been shown to be effective in various studies by increasing the space between the thyroid and the parathyroid. It also is supposed to create a pocket around the parathyroid, in turn protecting it from the injury. And this has been shown to be efficacious in terms of improving the hypocalcemia rates in the study by Coy et al. Now we would go into the venous engorgement or excision of the parathyroid glands intraoperatively as a cause of parathyroid injury. Now if there is a venous engorgement, the parathyroid will end up looking dusky, bluish in color. So if we just give a slit over it with the help of number 15 knife and the color restores back to normal, which is called capsulotomy, then it's fine. The parathyroid can be left intact. However, if the color of the parathyroid does not return back, then it is the time to do a parathyroid autotransplantation. And similar is the case if you end up accidentally injuring the vessel and you are not sure about the viability of the parathyroid, then just excise it and implant it in any of the sites, as in sternocleidomastoid or brachioradialis. It depends and varies from surgeon to surgeon. But yes, it does improve the rate of permanent hypocalcemia, though the rate of temporary hypocalcemia may increase post-parathyroid autotransplantation. Then sometimes the cause of parathyroid injury is the difficult anatomy itself. Now what is the difficult anatomy parts? This is the normal anatomy. Now this is the first where the inferior thyroid artery is actually piercing inside the thyroid parenchyma to go into the parathyroid. Now this is the point where you really cannot help, but you have to excise the parathyroid. I'm sorry. Yeah, and then this is another aberrant anatomy where the most important variable is the distance of parathyroid entry into the parathyroid and to the point where it enters the thyroid. Now, as we discussed in the Halsted maneuver, it should be excised close to the thyroid. Now, if this distance is less, then obviously there is a greater risk of damage to the parathyroid artery. And sometimes the parathyroid does not get its blood supply from inferior thyroid, but it gets it from the superior thyroid. And the superior thyroid artery pierces a large distance into the thyroid to reach the parathyroids. And this is the time when you cannot help, but you have to cut the arterial supply and then get it autotransplanted. Then difficult surgery. Yes, of course there can be difficult cases also in the form of toxic goiters, redo cases where you are doing a central compartment neck dissection or doing a resection of malignancies. Then the surgery itself might be so difficult and the localization may be difficult. So for that, various techniques have been advised. One of them is methylene blue, which is very readily available, intravenous methylene blue, or sometimes even the methylene blue spray. Then using near infrared autofluorescence or using optical coherence tomography or indocyanine green, as has been today presented by so many presenters, or a spectroscopy can also help the surgeon to localize the parathyroids. Carbon nanoparticles and fine needle aspiration and rapid parathyroid hormone have also been proposed to be helpful in localizing the parathyroids and confirming that it's a parathyroid tissue. Similarly, to assess whether the parathyroids are viable, indocyanine green fluorescence imaging and laser speckle contrast imaging have been shown to be useful. So my conclusion is that the gold standard still remains the Hellstead technique, the subcapsular ligation. But despite doing everything, there will still be 25% of cases where devascularization is inevitable and you need to auto-transplant the parathyroids. So surgeons should be aggressive in preserving the vascularity, but if the parathyroids are injured, then we should not hesitate to auto-transplant them rather than leaving them behind. So I think that's the message which I want to give. Thank you so much.
Thank you, Geetika. You are covering that well. Please join us here. And we'll move on to the last topic. I think Dr. Roma. No, she's not here. Yeah, she's here. Yeah. So Roma is going to talk about post-op hemorrhage and thyroid storm prevention.
Presentation. I sent it to Paul, sir.
Okay, no, it's emailed. Just give it. Okay, sorry. So while that is loaded, I'll just start with the questions on the panel. Just a quick question. Ravi Kumar, to my left, we are talking about the incisions for minimizing the scar. And he mentioned that MIVAP. I just asked from the audience, is anyone doing mini incision thyroid or MIVAP technique in any situation? Anyone, or it's completely given up? I think most people have gone from open bypass these two historical stages and on to endoscopic or robotic. In the MIVAP technique, one use I found recently was we had a parathyroid in a person who had a ankylosing spondylitis. So the neck was completely stuck in flexion and we couldn't really access for open approach. So there a lateral MIVAP approach helped. And there are a few patients who are still very finicky about the size of the scar, so you may use it. So this is something that's almost historical, but very rare utilization is there. So have you used it, Ravikman? No mini incisions. Okay. Yes, there's a point from the audience. That Barua, Sunil Barua. Okay. Okay. You mean the mini incision? Okay. Yes. Thanks for bringing up. Yes. Okay. Roma's ready. We'll start. Thank you.
Very good afternoon to all. So this is the last minute replacement for Dr. Roma Devi. So I'll be speaking on the most commonly mentioned complication by our MBBS student when they're asked what is the complication of thyroidectomy. So it's post-thyroidectomy hemorrhage. Incidence is around 0.6 to 2.9%. The most important critical time is the initial 6 hours. We need to know the cause in order to prevent it. So we need to see the cause is like loss of arterial ligature, collapsed vein, or any effort cuff, vomiting or blood pressure elevation. There are certain risk factors which are involved. So there was a beautiful systematic review and meta-analysis. These are the factors which I have highlighted, which were affecting the percentage of patients having hemorrhage. So, and in order to go, before going for the management, I will go for the prevention. Some tips and tricks which we need to keep revising, which I have been taught by my professors and colleagues. So meticulous hemostasis is very important in thyroid surgery. This we have been mentioning in all the, I think, lectures. Double ligation of figure of 8 ligation of the anterior jugular veins. This is also very important because we often tend to miss this anterior jugular vein. Even if you're not cutting the muscle, I think you need to better to tie these veins because these are very fragile veins. Special mention of the posterior branch of the superior thyroid artery. Special care needs to be taken while ligating that. Midline space closure during the closure, as you can see in this picture, so that if the hematoma is formed, you can easily visualize it. And then Valsalva maneuver already mentioned by Dr. Smita. The last one is to connect the drain. This is what I usually follow. Connect the drain while closing platysma, after closing the platysma, so that when you are putting the subcuticular sutures, you have enough time. And one of the patients actually of mine, I could detect before the patient was even extubated. So we could check where the bleeding was. Then we have to have smooth extubation without significant retching or cuffing. So what we usually do is a technician usually gives a gentle pressure on the neck during extubation. I don't know how much that helps, but definitely yes, we do that. Control of post-operating vomiting and pain to avoid an increase in venous and arterial pressure. And special care needs to be mentioned in the elderly individuals. I personally do not use energy devices in elderly individuals because these vessels are usually calcified. So ligation of the vessel, especially at the superior pole, this is what I prefer. Now coming to the management of these cases, post-operative hemorrhage, if it is mild, you can compress, and of course you need to replace the drains because the coagulum gets collected and you do not know how much it is actually bleeding inside. And in severe, we have all been taught about this, that bedside hematoma evacuation while you're preparing the OT, while the anesthetist gets ready with the intubation thing. Now coming to the next part of the complication, one is post-thyroidectomy's thyroid storm. This is a specific topic which Dr. Paul has given me. So thyroid storm is by definition represents the extreme of spectrum of thyrotoxicosis where decompensation of the organ function can occur. So this cause, again, in order to avoid these complications, you need to know the cause. Why has it happened? So most important cause is the poorly prepared patient or unprepared hyperthyroid patients taken for surgery. When we do not give a proper preoperative preparation for Graves' disease, this usually happens with people in earlier days of your career when you are really excited to operate on some Graves' patient. But definitely you need not do that. First need to control it properly. Then comes the functioning mets from follicular thyroid cancer. And also after subtotal thyroidectomy, the hyperactive tissue that is left behind. This last complication we usually do not encounter because we do not do subtotal thyroidectomy. Coming to the preparation, so as already mentioned before, proper pre-op preparation of hyperthyroid patients, rapid preparation if you need to urgently operate these patients, and total thyroidectomy should be the standard of procedure. And for functioning meds, you need to have high suspicion so that you can detect these patients early in post-operative course. Intervention, these patients of thyroid storm, I must emphasize, these should be managed in ICU setup. General supportive care needs to be given. Thyroid-specific therapy to be given only for cases of metastatic thyroid cancer and if subtotal was done. Maintenance therapy and some emerging treatments. So general supportive care includes cooling measures, electrolyte replacement, nutritional support, haloperidol. You need to calm these patients. These are very anxious patients. Cardioversion by defibrillation if tachyarrhythmias. These are some emerging treatments. I didn't happen to have any case of post-thyroidectomy thyroid storm, but I had an experience of post-parathyroidectomy thyroid storm. So I would just like to highlight this case. She was a young girl, 23-year-old with fracture. She was detected, a diagnosis of primary hyperparathyroidism made. It was a concordant imaging. We did surgery. It was around 5,700 milligram of parathyroid. Frozen was parathyroid tissue. Patient was fine. IOPTH had a 50% drop. Post-operatively, patient developed hypocalcemia. We managed her with IV infusion. So on the sixth post-operative day, this patient had sudden febrile episodes, which were occurring every 5 to 6 hours. And my residents were managing with IV PCM. And then on the 7th post-op, she suddenly had tachycardia of 140 to 160. This was a variable pulse rate that she had. And she was very anxious, agitated, and she was actually tossing on the bed, and I really couldn't understand what was happening to her. So it was actually giving me tachycardia as well when this absolutely fine patient I was about to discharge that day. So T-sign, I also had maybe this, she's again going into hypocalcemia, though calciums were normal. So we did a free T4 level, which was high. Before this report was available, I had the suspicion, so I already started her on propranolol, beta blockers, which actually gave a lot of relief to her. So symptomatic treatment was done. So a diagnosis of post-parathyroidectomy thyrotoxicosis or thyroid storm was made. So the rate of post-operative hyperthyroidism after parathyroidectomy is pretty high. It's up to tune of 20%. However, we do not detect that because there are very few patients who actually develop clinical symptoms. So maybe if we repeat these tests immediately post-operatively after we may get more patients. So the main causes which in one study they mentioned is when you go for bilateral neck exploration, you are manipulating the thyroid. So basically when I went back and I thought about my surgical procedure, maybe I actually manipulated the thyroid a lot because it was a large parathyroid adenoma and I was trying to save the thyroid, though it was little stuck to the thyroid. So maybe in normal case I would have done a hemithyroidectomy because of suspicion of some parathyroid C or atypical parathyroid adenoma. But since she was a young girl, I was preferring I should save the thyroid. So maybe that was the reason which led to this. So that's all. Thank you.
Thank you, Dr. Omar, for taking this on a short notice. While you're there, I think what this is referred to sometimes is palpation thyroiditis. When we, of course, the other issue is toxic goiters, which we can't fully control, and then you have to give them steroid or beta blocker post-op. That's more common, but this has been described as palpation. Anyone experienced palpation thyroiditis? It rarely presents clinically as well. That's true.
Not in the pre-op setting, but one case I think Dr. Pooja encountered recently, if she could discuss that. It was a pretty interesting case of post-thyroidectomy thyrotoxicosis and storm. Would you like to discuss? We were just discussing while we were traveling from Lucknow, so I thought.
Yeah, it was a very challenging and difficult case. This was follicular thyroid cancer with the lung and skeletal metastasis. She is 60 years lady with paraparesis. So we did total thyroidectomy for her. She had preoperatively hypercalcemia of malignancy, which was also managed before surgery. And after surgery, just because we had given zoledronic acid also, because hypercalcemia was not getting controlled, she had hypocalcemia also, post-op. So she was staying till 5th post-operative day with us. On the 5th post-operative day, suddenly she became very restless, tachycardia, heart rate more than 140, 160. So we didn't understood what has really happened. So one differential in our mind was thyroid storm. She didn't had any fever. So that was confusing the picture, but only tachycardia was a thing. So we started esmolol infusion, propranolol, steroids for her. Then cardiologist was called bedside. So they did echo, just hypokinesia was there. Otherwise, ejection fraction was some 45-50%. She didn't had any MI sort of a thing. TROP-T was normal. Pro-BNP was elevated. So with the steroids and all this, slightly her tachycardia was slightly controlled, but heart rate still was 130 sort of a thing. Otherwise, she was stable.
What were the enzyme levels? You measured the enzymes?
This pro-BNP was 11,000.
Thyroid
functions, we had sent that urgently in the lab. T4 was 22. The upper limit is 12.
Okay.
And free T4 also was elevated. TSH was suppressed. But preoperatively, she was euthyroid. So she didn't had that, but this happened on day 5. Then early morning, 5 a.m., she had a cardiac arrest and she succumbed.
Oh.
So I
this
think
was a total thyroidectomy?
This post-total thyroidectomy. She was just staying longer because of correction for hypocalcemia.
So that doesn't make sense. I don't know whether bone metastasis can produce.
Yeah, because of the functional mets. That is what I mentioned in one of my slides too.
Okay. But how will you explain hypokinesia in echo with a hyperthyroidicity?
No, in hyperthyroidism, you can have cardiac changes. You have arrhythmias also.
And these are sudden cardiac.
These are sudden events. So maybe she had that and she worsened.
And about the fever, usually in the elderly, it doesn't present as fever. These episodes are usually present in younger patients when we get thyroid storm. So elderly is more of cardiac events that happen.
That I learned from Roma, that I was telling her, but this patient didn't have fever, but we had kept in mind, that's why we sent urgently thyroid functions just to prove that whether she has or not, though we steroids this. Once the report came, then we started numercazole also.
Yeah,
Because
that's like
whenever
what
a
we
patient
call.
comes with such post-surgery, we get this tachycardia 140 something. So we do think of pulmonary embolism, which I thought in my patient as well because she had fracture similarly to her patient. So, but actually thyroid storm we need to keep in mind, which is very common.
Thank you. Thank you for that. We'll just quickly go through the other points. One, first starting with the extent of surgery. Would anybody like to share? I think one of the common challenges we face even when we have a solitary nodule and it's a hemithyroidectomy situation. How many of you find that when you counsel the patient fully, I think what we want to avoid is a situation where you've done a hemi and then you have to tell the patient you need a second surgery. So when we counsel them that there is a risk of second surgery, what we find is many of them opt, say, just do the total, we don't want to have a second for cost and logistic reasons. So is that a common issue you have faced? What would you say I mean, if you're in a setup where it's covered, it's different, but what would you say is a percentage, say, Dr. Sinu, of hemis that you're doing now? Because the hemi rates have fallen for us quite significantly. Second surgery. Right. Yes, Anjali?
So, Paul, actually, when I used to be resident, probably we were doing more total. And I think it depends how you counsel the patient. And also depends what is the patient's profile is. Like if a young girl comes and then you have to tell why this thing, like it is a follicular neoplasm, that is category 3. So what are pros and cons? So we always tell there is 20 to 30% chance that you may have to undergo second surgery. Considering young age, it would be lesser. And if half of the thyroid is intact, it is possible that you need not to take lifelong medicine. So in many of such cases, nowadays I am observing that patients prefer to undergo hemithyroidectomy. So, but if give weightage to, you are likely to have cancer. So patient would opt for total thyroidectomy. So it's the way how we counsel, that's what I feel. I still say that the chances of cancers are there, but it is lesser. There are more chances that it will turn out to be benign.
Okay, thank you for that. Yeah, please, Geetika.
Okay. Ma'am, you are very right in saying that, but I would also bring it to the light that sometimes you really counsel the patient when you're not sure and you give the options for both. And then looking at sometimes the age of the patient and everything, you decide to do a hemithyroidectomy because I think in our setup, mostly patients do not choose for themselves and they let the doctors choose. You give that benefit of doubt and end up doing a hemithyroidectomy. But I also have faced problems when it turns out to be malignant and the patient will actually be, they may not say anything on your face, but they would be very angry. And then they would go to some other center. For us, it's like they go to PGI. And then somebody will randomly tell them, I'm not saying you, ma'am, but somebody will randomly tell them कि वो तो पहले ही पता चल जाता उनको, उन्होंने ठीक से कराया नहीं. And then No, I have faced 2 cases, ma'am.
Thank you. Yes. Okay, yes.
But if you are preferring a hemithyroidectomy, especially in an indeterminate nodule state, and if the patient is wise, like as mentioned, and they prefer a hemithyroidectomy, so always consider the imaging features, clinical features, everything. And if the patient insisting on hemithyroidectomy, make it sure you are dealing the nodes properly. Especially, definitely explore for the same side lateral nodes, and imaging wise you look for bilateral nodes. And if there is suspicious node, don't never hesitate, go for a frozen section biopsy. And if definitely see the ipsilateral central compartment. I think, what's your opinion?
Yeah, sir, I have this
Yes,
thing.
the last comment.
Yeah.
We're running
The
out of
last,
time.
the patients that I am seeing are exactly opposite to what exactly you have said. So most of them would like to conserve their thyroid. And I see very few patients who actually would say, no, no, take off all my thyroid. Yeah, if I get a recurrence, I'll take it later. This is for the benign goiters. And yeah, frozen section, I was never using, we hardly use frozen section occasionally when it is, but whenever I'm doing a hemi, it's frozen section is a must. And the other
for
thing,
the nodes, yeah.
Yeah, not for, I'm sending
Sir,
for the
if you go for the
thyroid.
frozen section as such, for nodes having a good high sensitivity in frozen section biopsy, so I consider only for nodes only, for frozen.
Yeah.
If you go through the literature for thyroid lobes, the sensitivity is as low as sometimes 20% and all. So we can't afford to do a frozen section for the lobe.
Yeah, I mean, I was also,
and
but now I don't,
another extension to that is, if you are going for a hemithyroidectomy in a benign nodule, the patient selection is important because I prefer to operate larger nodules in solitary thyroidal benign nodules for hemithyroidectomy. If you are operating a 4 centimeter benign nodule, that is what there in the literature also. Contralateral involvement, chances more. If you see in the literature I presented, if you are operating a unilobular, that means solitary nodule, benign nodule, larger nodules, chance of recurrence on the opposite side is more. Maybe most cases will be, they pooled will be large nodule.
I think the profile of patient differ. I mean, when a well-educated patient comes, he will be.
Yeah, no, I
asking all
absolutely agree. Cost and logistics
Cost
is
and
the main
logistics
issue.
is the
It
main
will
issue,
divide into
yeah.
two. So thank you very much. We've run out of time, unfortunately, so we'll move on to the next session. Thank you. Thank you to the panelists. A hand for them. Thank you.
Thank you, Paul, sir. A request to the audience, please make some time to visit the stalls that are put up by various industries. It's just behind the auditorium. They are here to showcase their products, and definitely without their support, this program would have not been possible. Moving on to the next session, it's on special plenary lectures. So I invite Dr. Anjali Mishra as a chairperson for the first lecture. This will be on transoral thyroidectomy that will be presented by Dr. Anuwong. Here, sir will be joining us through the Zoom.
Yeah, good afternoon, everyone. So we are here for a special plenary lecture, and I think Dr. Angkoon does not require any introduction. So it is my honor to introduce you, and he's the one who has introduced this concept of transoral endoscopic vestibular thyroidectomy. So here we are. Has he joined? So we have some time, so there is some. Okay, so he has already sent his video, so I'll ask organizers to play it. Thank you.
Okay, thank you very much for inviting me to have my presentation in the Indian Endocrine Surgery Society at this time. Thank you very much for inviting me to have my presentation in the Indian Endocrine Surgery Society at this time. Because I could not make it to India this time, so I sent my video instead. Well, I will present my 2,500 cases in 8 years of the transfer endoscopic thyroidectomy vestibular approach or TOETVA. As you may know that the journey of the transfer thyroidectomy started from 2010 in Germany by Professor Elias Karakas. This is the first paper described about the transfer thyroidectomy, but on that time he decided to have the flagma operation. And during 2010 to 2014, I had my experience and opportunity to meet this kind of people. Well, these kind of people were the pioneers of this transfer thyroidectomy. We share our knowledge together. We help each other to make this happen. Back in Thailand in 2014, I changed my concept from the flop operation, but I thought this is not that quite good because our patients had the very traumatic tissue after operation. I changed from the flop operation into the orovestibular area. The orovestibular area is the area between the lower lips and the lower teeth, which is quite at the center of this time. So which is, I think that this is quite great in movement and the kind of the making the expansion of the working space as well. So this my story started from 28 March 2014. This is the female, 45 years old, with right thyroid to 2 centimeters. You can see that the pictures 2 cm is not that quite obvious, but this is 2 days after surgery, so she looks similar. And if you see the operative film that time, the op film is not that good because of this was the first case of mine. I posted it on Facebook at that time. Well, in present day, if you search and make some research, you may find that the TOETVA is expanding into 45 countries around the world. Well, this is the list of the countries that the surgeons on that country still can perform this TOETVA. You can see that it is included in all continents around the world, especially in Asia, Europe, and right now I think in South America they are very popular among in Brazil, in Argentina, in Peru, Ecuador as well. They're very crazy about the TOETVA. And if you search in PubMed, you can see that the search term TOETVA, the numbers of applications is increasing. And you can see it, you can search by yourself. It means that this operation is quite popular right now. Well, this is the most questions I have ever been asked before, because when I met new surgeons or even patients, they were asking me that, oh, doctor, is this safe enough because of we make the incision inside the mouth that is very dirty and plenty of bacteria, and they will go down to the sterile area and they flip and change the concept of the operation. It is really safe. So this is my answer, because in 2000 and I think 16 or 17, I have published my paper in the JAMA surgery, which have the second most impact factors in the surgery field. Well, I make the comparison between 2 groups, around 200 cases, open group and the transoral thyroidectomy TOETVA group. So you can see that the both parameters in 2 groups was quite similar, except 2 things. The first thing is that operative time. The transoral thyroidectomy has longer operative time than open thyroidectomy, significantly around 30 minutes. Oh, this is understandable because of we got to have some time for equipment preparation, flap dissection, pot insertion. It's not like the open that we make incision at the neck area right away. So 30 minutes is quite understandable. But interestingly, that you can see the pain score. TOETVA has less pain than open group. This is quite interesting. Well, I would say that some of you, if you started to do this operation, you may find that, oh, why TOETVA have very high pain score? I would say that is from the part of experience. If you are an experienced surgeon, you may dissect less than an experienced surgeon. It means that the tissue trauma that is less, it means result, the patients have less pain. Trust me, if you have more experience, the patients have less pain. So, but the other parameters, just like blood loss or complication, was just the same. It's not different at all. So we could say that TOETVA is safe enough comparing to open thyroidectomy. In my AJ experience in 2005 cases, this is my complications at core. I have 1 case of hematoma, 3 days of the operation. I have 6 cases has to be converted into open surgery because the size of the thyroid is so big and the bleeding is coming. 1 case just the infection, and we treat the patients just like aspiration and put the drain in, something like that. No need to open the neck. I have less than 3% the transient cord palsy, and I can see that the numbers quite good in my experience. This is the another series from American surgeons, I think from Johns Hopkins University, I think. They make the comparison just the same as mine. You can see that operative time is longer in TOETVA than the open. This is just the same thing. And the complications, even major or minor complication, was just the same. It's not different. It's not different at all. Well, the Johns Hopkins in the United States result and my result was quite the same. that support that TOETVA is very safe right now. So another multi-center study from Brazil in 2014 patients, you can see that in 412 patients, sorry about that, you can see the complications is just quite low. You can see that, and this is confirmed that this kind of operation is quite good. This is another meta-analysis from Taiwan or China, something like that. And they collect the data from papers all around the world, and they have found that yes, as the operative time is longer in TOETVA, but other parameters was just the same. It's not different at all. This can be confirmed. This is another confirmation that the TOETVA is quite safe. So another question is that TOETVA in cancer, possible to do that? Because of some of you or even some socials may afraid that we cannot remove them all. We have to leave some tissue or not. So I will review my point of view, my perspective. In my experience, we know that in Thailand we have around 10 to 15% of thyroid cancer. If 100 cases of the thyroid nodule, only 10 to 15% is cancer. So in my experience of 2,500 cases, I have around 354 cases of TOETVA made in thyroid cancer. So 154 cases has lobectomy first and final pathological result with cancer. 50 cases decided to have active surveillance later because of the pre-microcarcinoma. 104 cases had decided to make a completion thrombectomy, and we have 200 cases we pre-op diagnosis as cancer before operation. And as you can see, the data is that right now I did around most of the cases is just like 1 to 2 cm thyroid cancer site that we adopt or we use the TOETVA to operate this kind of patient. And 8 years follow-up among the 354 cases, no death right now. And we have only 3 cases of the lymph node recurrence, just like 0.84%. When we explore into all 3 cases, that occurred in my first 1 or 2 years operation. I mean, the first operation occurred in my first 1 or 2 years operation. Because on that time, I have less experience on present day. This means that the movement on the dissecting tissue technique is different. So, and on that time, I did not dissect the lymph node at all, just total thrombectomy in all 3 cases. And tumor size quite big, just like 4, 3, and 1.8 centimeters. And when I review the videos, I have found that that operation is very, very difficult because of bleeding, and I have to leave some part of the thyroid tissue in the very ligament. That's why later they have the lymph node recurrence in 3 cases. And I have to make the electronic dissection in 2 or 3 years later. So when you search another paper, you can find that this is the data from Korea with the TOETVA. You can see that they operate in thyroid cancer as well. And the Brazilian papers in the 400 cases, they did in, you can see the numbers that they most did in the cancer. Because the 5, 6, they have so many cases. So this is to be confirmed that we can still do this kind of operation in cancer as well. But I have some recommendation. If you're the beginner, do not jump the TOETVA performing thyroid cancer yet. You have to pass the learning curve, maybe 10 to 20 or maybe 30 to 40 cases to gain your confidence because you jump into this kind of operation. And case selection, the tumor of the cancer size must be 1 or 2 centimeters. And if you have more experience, you can use 3 centimeters CM, 3 cm with thyroid cancer as well. For me right now, I change from 2 centimeters to 3 centimeters, the upper limit of the thyroid cancer. Because you may imagine that if the cancer is greater than 3 centimeters, it is very difficult to remove from the central incision. But if you still want to dissect the thyroid cancer using the TOETVA, you can make the incision at the axilla to remove them all. I mean, remove thyroid cancer using the endo bag. This you can do. And don't forget to perform the routine central lymph node dissection. For me right now, if I operating cancer, central lymph node dissection is my mandatory manual to perform. Central lymph node dissection using 12 is very easy. This means that lymph node level 6 or maybe 7, because it located just straight away. You can usually see that. This is the example of the operative field. This is the coracoid cartilage, this is the isthmus, right strap muscle, left strap muscle. The lymph node is here, must be here, central, left and right is quite easy. Yes, it's over there. So this is lymph node number 6. I have the video. I did the left and right thyroidectomy already, so you can see that I am now remove the lymph node number 6, left and right in the center. I use the harmonic of the harmonic. You can see that this is the carotid artery. I am now finishing the lymph node dissection. You can see the clear view of the operative area. Left no tissue, no lymph node. This is auricular lymph node. This is the right carotid artery. So it is very clear, and straight away you can perform it very easy. No worry. More advanced about the TOETVA, I introduced you into one of my advanced techniques to perform the modified radical neck lymph node dissection using TOETVA. This is another step. If you can do the central lymph node dissection very easy, and you have more confidence enough, you have to jump into another level. This is modified radical lymph node dissection. But I would say that maybe not the right time, because of the limitation is lymph node level 2. Level 2 is up here. You can imagine that when we insert the port here, the tip of the port, a camera should be around here, around the cricoid or thyroid cartilage. It is very difficult to drag or to dissect here, lymph node number 2, using the equipment, until you have the better instrument in the future, or maybe flexible robot in the future. But you can still try to do it in selected patients. How? I will tell you later. So as I told you that the limitations of the modified radical neck lymph node dissection is lymph node level 2 is here. Should be here. This is level 6, right? 3, 4, 5 over here, this area. But level 2 is here. The camera cannot see. And sometimes if you look from the external surface of the patient, it could be around here. It is very difficult. Actually, I did in 3 cases, in selected cases, starting from June 2020. This is my first TOETVA right MIND in very selective case. The challenging is lymph node number 2. You have to have the very good and excellent hand skill with the cameraman as well. So this is the modified radical dissection. The tip is that you have to, sometimes you have to use 30 degrees, sometimes you have to use 45 degrees. The flexible camera also very useful as well. So in this case, in the video, I did the total thyroidectomy already, and I did the central lymph node dissection already. Well, I will show you that. This is the tray here. You can see that. This is the carotid artery. This is strap muscle. Yeah, this is the area between jugular veins here. Internal jugular vein. This is the carotid artery. This is the tray here. This is the lymph node. Number 5 and 4, I drag it starting from here. And then you need to open the muscle up here using the elbow. And you have to drag it down there. You have to drag it. Sometimes you change the camera to 45 degrees. That is perfect. And then you drag it until you got the level 2. This is the technique. And you have to be careful because sometimes you may find the nerve, so many nerves here, it's important nerve that the technique is to drag it down until you got everything. Well, it's quite difficult. It took me 1.5 hours, especially 1.5 hours for the right side lymph node dissection. You can see that straight here, auricular nerve, carotid artery, internal jugular vein. This is the base of your muscle. So level 2, 4, 5, 2, 3, 4, 5 level numbers has been evacuated already. So you have to use 45 degree and try to look inside here and make a back down here. So that's it. That's what I did. So this is the specimen. Left thyroid, right thyroid, level 6 and 7. This is lymph node number 2, 3, 4, 5, A, 5B. In these patients, I remove it just like the one piece, not like the cherry picking. Do not do that. It's just one piece in bulking. So I would say that in my recommendation, you have to, if your patients have the lateral neck lymph node metastasis, you have to choose the appropriate. In this case, she had the lymph node number 4, only 4 and 5 metastasis. No number 3 and number 2. That's why I decided to make this calculation in this patient. So this is post-op day 1 with the MIND on the right side. No drain was placed because if you may see it, it feels quite clean. And this patient lost only 30 milliliters of the blood loss. That's it. That's why I decided not to put the drain. And the pentacle is only 2. This is the stitch hole. I make the stitch and just like it hanging up. You can see that this is stitch. This is a stitch. That's it. So no drain. So the final pathological result in this case will be 2.1 centimeters in right thyroid with the lymphovascular invasion and the central lymph node dissection about 5 positive out of the 19th node, and the right cervical lymph node over 2 to 5, they have only 2 positive of 21 nodes metastasis, and the size 1.2 centimeters, larger dimension. So after operation, I send the patients to have the iodine ablation, and we monitor the thyroid scan and TG and anti-TG is less than 1. In 1 year follow-up, almost 2 right now, is no recurrent yet. That's why these patients have the quite good surgical result. And I think that I searched in the papers who did the same thing as mine. I found one paper in China. They tried to do the transendoscopic, but they did the selective lateral neck dissection, not the modify the whole lymph node dissection. They cut only level 3 and level 4. They have a problem with the level 2 dissection, as I mentioned earlier. In Vietnam, they did the same thing, but they added 4th port. They used my technique because they used you can see that the 3-trocar Anuwong technique. This is my technique, but they used the additional port. So they used the 4 port inside, and they remove level 2, 3, 4. It's just, I'm not sure why they don't remove number 5 as well, 5 and 6, but they have written in their paper that they remove something like this. So I have a friend who tried to do the same thing. Another advanced technique is to use the nerve modulator with the, as you may know that in my country, nerve modulator is quite, the patient has to pay additional cost for the nerve modulator. But at first, in my first 3 or 4 years, I did not use this because I did not see the value of the nerve modulator. But right now, I changed my mind because sometimes I found some quite difficult situation to identify where is the real nerve on the nerve cord. So in this case, you can see that this quite maybe nerve quite helpful very much for us to see and to find the cause of the nerve is quite useful. So I think it should be standard in every cases, not only to confirm the nerve, but we can use it to find the external branch of the superior lymph nerve as well. And use it to trace the nerve causal direction. And you can see that in the video. And we can use it to confirm the anterior branch and posterior branch of the auricular lymph nerves. This is very, very important because right now I have found around 30% of the anterior branch. So the auricular lymph nerve is located here. You can see that sometimes it's very difficult and sometimes it's very easy. For the right side, it's a little bit tricky because you have to push the gland here and it will make a parallel here and insert it here. It's almost away. So right now, I almost always find the nerve before cut, but I find 100%. I have found just underneath the thyroid. For the left, so what about this situation? You can see that what is it? Because you can see this is that we cut the superior artery and we push the gland to the left side and we try to going to find the parathyroid, and I found here. If you don't care enough, maybe you can cut it already and you thought that this is maybe the vessel, but it's not the vessel in this case. You can see the video. This is vessel or not? No. When we carefully dissect it, we see something. We will see something that, oh, this is the nerve. You can see that. And make a U-turn here. Not U-turn down there, but here. Yes, this is the non-auricular lymph nerve. You can see that. Make a hanging and a U-turn here. Yeah, is this a non-auricular lymph nerve here? This is a carotid. Be careful when you make the operation. So in my 2000, it's around 2,500 cases, I have found 5 cases of the right side non-auricular lymph nerve like this and like this as well. You can see that. This is to prove that you have to remember with your own eye that this is the colors of the nerve inside the endoscopic view, not the if you not sure about this, you can use the nerve model or you have to dissect. Don't cut yet, just dissect to see what happened. So the last thing in my advanced technique is that right now I am using the ICG. This is, if you want to use the TOETVA with ICG, you have to use the laparoscopic system with IR and I are integrated. Right now they have Stryker, they have Transtros, and they have Olympus system as well, and you can use the ITC solution to detect the parathyroid. So the usefulness of the ICG in the thyroid and parathyroid is that for thyroidectomy, I have to propose in using the ICG. The first objective is to confirm the viability of the thyroidectomy to predict the PTH post-op. You can see the this is I did the left lobectomy already. So this is maybe the parathyroid. So I inject the ICG and see it is green or not. It can help us to tell that the parathyroid is viable or not. You can see that this green is partial staining. This is the grade 1. This is not the grade 2. This is grade 1. This means that this parathyroid might have the lack of blood supply, some part of blood supply lacking. So you can see that it will turn into black and white. You can see that this is a partial staining truly. So this is a score grading from the paper from Switzerland. They made a score grading from ICG injection. This is the score 2. You can see that this is the full staining. The grade 1 is partial staining and grade 0 is no staining. So in grade 0 or grade 1 you have to give the patients the calcium supplementation post-operatively immediately. For grade 2 you find. So the objective number 2 is to help and confirm and identify parathyroid before thyroidectomy, because sometimes you cut it, you not realize that this is parathyroid or not. You cut it already. You cannot see and you cannot have the parathyroid to detect after surgery. This objective is to help you to confirm it. That's why. But At first, you have to identify to see the suspected parathyroid first. You can see that this is the right lobectomy. I did not cut the thyroid yet. I just cut the superior pole and push it and rotate it to other side, and I found something like this. You can see that. I suspected that this is parathyroid. It could be right or could be not. I don't know that. Then I inject the ICG and you can see that the ICG is running in your vessel and then supply the parathyroid first. So you have maybe 5 to 10 seconds for parathyroid itself is glowing before everything is green. So parathyroid will be glow first 5 to 10 seconds. It grab your attention that this is the parathyroid. This is to be confirmed that, oh, this is parathyroid. All we have to do is just cut above it, and save it. This is the usefulness. And this is another example to see that this is the left upper parathyroid gland. We inject the ICG. You can see that. And you can see the green of the parathyroid 5 to 10 seconds before everything is green. So if you let the gland to maybe more time, the anti-thyroid gland will be green as well. This is a black and white. You can see that this is quite bright to confirm that this is a parathyroid. Okay, in conclusion, I think right now TOETVA is popular nowadays. It has produced excellent cosmetic result. I think it is safe enough compared to open appendectomy, but you got to have the learning curve and sometimes excellent lab instrument as well, laparoscopic instrument. It can be done safely in selected thyroid cancer. Thank you very much. Okay, thank you very much for inviting me to have my presentation in the Indian Endocrine Surgery Society in this time, because I could not make it to India this time.
So thank you. That is the end of the lecture. I guess there can't be any questions. Is there any comment from the floor? Paul?
On par with the open, with or nearly, I mean, except as you said for level 2 can be difficult. There is a learning curve, I think that's the main point. And usually you need some lab experience before you get into this. But the experience has been that the patients are really happy with this outcome. I think that is the take home, more than any of the other extracervical approaches. So it is something to consider for all young surgeons who are getting into this. Main thing, get your lab skills right, and then TOETVA is a very excellent technique. I don't know anyone doing TOETVA for malignancies yet. I think we've had 2 incidental malignancies, but we are not, with the preoperative diagnosis of a malignancy, we haven't yet gone down that route. Siddharth? All incidentally, I say. So I don't think here yet we've gotten into that, but yeah.
Dr. Gyan has started doing for smaller cancers, but not for lateral nodes. Baba, he's doing regular lateral node dissection.
Okay, sure. So 1 to 2 centimeter well encapsulated, I think, is reasonable to start once you're okay with the technique. Okay, thanks.
Okay, thank you. If there is no other comment and question, I'll close this session. Thank you very much.
Thank you, ma'am. Now I call upon Dr. Abhishek Krishna and Dr. Pooja Ramakant to chair the second special plenary lecture. This will be presented by Professor James Lee, who will be joining us through Zoom. And
Good afternoon, everyone.
The topic of presentation would be on evolution of thyroid surgery.